الكريم الأكحلي، الأستاذة العزيزة سامية حيدر، دكتورة مها نبيل، أستاذة خديجة الهجري، الأستاذة سماح البيضاني، الأستاذة سميحة البيضاني، الأستاذة إلهام فاضل، الأستاذة بلقيس العواضي، الأستاذة هند الحداد، الأستاذة فاطمة الرداعي، والأستاذة سميرة النجاشي، كل هؤلاء كانوا مشاركين في إنجاز الورشة السابقة لهذا الموضوع. الدكتورة العزيزة إيمان التوا، والدكتورة العزيزة رقية الشهاري، هذا اللي موجودين معي. هذا دكتور، هذا الشهادات الذي حق الورشه، هذا الشغل شهاده الورشه. مش عارف الدكتوره سلوى موجوده ولا مش؟
بقيه الشركات الداعمه
خلاص باقي شيء
خلاص يتم.
هذا بالحكى.
انا
اوكي جون I'm leaving for now.
الجائزه محسوبه.
شكرا للجميع، شكرا للضيوف على وجودهم وعلى تشريفهم لنا. نشكر الجميع. نعود لفعاليات المؤتمر. انا بالنسبه لي اشكر الجميع شكر خاص جدا للدكتور، يعني طبعا بدون ما نبخس حد، لكن اللي كان مميزين وبذلوا جهد كبير الدكتور اسماعيل الغوثي، الدكتور احمد الجرادي، الدكتور احمد شرف الدين، الدكتور عادل القريبي، وكل من عمل في هذا المؤتمر. ونعود لفعالية المؤتمر. شكرا جزيلا لكم، ونرجو من الجميع الحضور. والغدا هنا ما حد سمع الغدا هنا. إذا بقيتم هنا سوف يكون هناك شيء جميل، انتظروا في داخل القاعة مش زي أمس. أيوة طبعا كل الشركات الخارجية وهذا التفاعل العربي والدولي بيد فعل التنسيق الرائع والمميز للدكتور العزيز أحمد الجرادي. تحية للدكتور أحمد الجرادي. تنسيق الذي يمسك ترجيع.
تكلم هذا تفلت هذا
الزوم ده احنا الزوم الان.
ايوه هو داخل
مع الزوم الان مفتوح. هذا مصاب الزوم الصوت.
ايوه
يوم ميت
صح.
الصوره حق ترجيع ملابس خلفيه.
ايوه واضح
الصوره حق ترجيع الصوره حق ملابس خلفيه حق ترجيع. هذه ترجيع ما اعرف.
John, can you hear me?
Yes.
Okay. Now we will resume our program. Sorry for the delay.
I'm not ready to start. Hold on.
Can we resume our program now?
I'll let you know when I'm ready to start, okay?
Okay, I'm waiting.
Okay.
اول ما يبدا بعدين نفعل الصوره حق تسجيل ونكرم ونبدا محاضره مسجله حقه.
Okay, very good. Hold on. Let me introduce you. Okay, hold on. I'm gotta go live.
تسجيل الله يهديكم معكم عن تلفوني.
Okay, are you ready, Ahmed? Are you ready?
Yes, yes.
Okay, this is Dr. John Bennett. We're rebroadcasting. We had some technical difficulties. We got things back online, and Ahmed is going to arrange for the next couple of speakers. Good day, Ahmed.
Welcome everyone to our second session of the 5th Neurosurgical Conference. We have some unexpected delay and some technical issues. Sorry for all about that. Now we will have a recorded lecture for Professor Ghazi Muhammad Yasarjil. But before that, we want to have some announcement. Our
تكريم مش معناه تكريم بالانجليزي.
award or certificate for Professor Yasarjil, and we will have now a group picture with the certificate for Professor Yasarjil, and after that we will have his recorded lecture. Okay.
دحان دحان يا دحان. هذا
لا لا خلاص اضغط عليه على شيء. بس لا لا ادخل.
يا سلام عندك احسن.
لا ادخل لا.
عنده احسن سباع. افتح بسرعه.
فتحنا اللابتوب يا سمين، فتحنا اللابتوب وبعدين قلبت الشاشه من
الكاميرا مان المصور يا شباب، المصور صور الستيج، مش الصوره حق الزوم تكون في الستيج. دكتور محمد، دكتور مجاهد، دكتور مجاهد خليك سريع يا سمير، خليك سريع. المحاضرة عندك الفيديو حق تسجيل ولا لا؟
ليش ما ارسلت لي من قبل؟
ايش؟
ليش ما ارسلت لي صورة من قبل؟
هذا احنا فكرنا بهذا الحين. كان الحين اول شيء يشتري يفتح ما عملت.
المدارس الاختبار القادم يعيدون. بس الثانية الأولى على جامعة
هيا معلك. ايوه وبعدين افتح المحاضرة مسجلة.
Okay, John.
Yes.
Now we have a quick reward for Professor Sergil, and after that we will start. After that we will start the recorded lecture provided by Professor Sergil. Okay.
Okay.
ايوه انا صورة حق زوم جهانا. ايش عملت شير ولا ما سويت؟ ليش الواد بورد؟ افتح عملت سكرين شير، عملت سكرين شير ولا اي شيء ولا هذا. هيا اكتب. يا اخي شوف خلي المصور يصور الستيج، المصور صورتنا هنا بتطلع في الزوم الستيج بدل ما بيطلع انا وانت بتجابر بقى الحين. يصور الستيج مع صورة الخلفيه حق سرجيل. الستيج مع الخلفيه حق سرجيل. هيا مالكم. هذا الستيج، صور الستيج الشاشه مع هذا مالكم. ايوه هذا اللي ظاهر انت الشاشه، اللي ظاهر في الشاشه الشيء يطلع في الزوم. تمام. افتح المحاضرة. في هذا المحاضرة حقه. اصبر انا ما قالك نزلت. ايش خلصوا ما خلصوا. ايوه هذا محاضرة حقه. لا ما سكرين شير لها.
We are in the fifth annual Neurosurgical Conference, and the Yemen Neurosurgical Society are grateful and give their thanks for Professor Ghazi Sergil for participating in our conference, and we thank him for his always support. And we give our thanks also to all speakers and all attendants. Now we'll have a group picture with the picture of Professor Sergil, and after that we will start directly with the recorded lecture of Professor Sergil.
خلاص خلصوا التكريم، خلصوا التصوير يا شباب، صورتوا.
شفت حاجه عن راحتك. دكتور احمد تعال.
June, can you hear me?
June. June Bennett.
يا سماع الصوت حق الدم مش طالع، الصوت حق الدم مش طالع، الصوت حق الدم مش طالع. انت يعني تحت الصوت حق الزوم. الحين تحت الزوم ولا؟ يا جماعه افتحوا الزوم الله يهديكم، مالكم؟
الزوم هو ذا.
الحين هذا زوم ولا لا؟ بس اعمل سكرين شير. يا عبد الله، يا سمير، تعال اعمل سكرين المحاضره الفيديو يكون في الزوم. الفيديو
لا اخي هو دخلها انا.
ما خرجش حاجه، هذا على ما هو. June, can you hear me? June. June, we cannot hear you. Are you muted? You are muted, June. We cannot hear you.
Please unmute the voice.
Yeah, okay, we're all set.
June now. شباب عبد الرحمن ايش المشكله؟
Okay, you ready to introduce Dr. Yazagil?
June, do you hear me, June?
Yes, go ahead, introduce Dr. Yazagil.
Okay, now we will share the recorded lecture of Professor Yazagil, okay? Do you see the lecture? Do you see the screen?
Yes, perfect.
Okay, I will start now. الصوت حق البرنامج على الصوت. الفيديو حقنا، الفيديو حقنا اين الصوت حق الفيديو؟ الفيديو احنا فاتح مشاه.
Okay, the video stopped. Okay.
Do you hear sound from video? We cannot hear here. Is the sound clear?
No, we cannot hear the video.
The sound of video, is it clear or no?
No. We cannot hear the video. You have to turn the screen on. When you share the screen, you have to make sure you click the sound. Did you do that? Let's go. Can you start the share again, please? I'll show you where it is. Okay, get off the screen share, whoever's doing the video, and start the screen share again, please. Can you start the screen share? Okay, when you start the screen share, click on the share the screen. At the bottom left, you'll say play the sound. It'll say play the sound. Okay, when you open the screen to share, there's a little box in the corner that says share the sound. Okay?
Experiences
Okay, now.
by animals.
Okay.
Dear colleagues, I enjoy very much to have the chance to talk to you, to tell a little from my experiences. It is clear that the human being have been since millenniums interested to control the bleedings by injuries, and they have been very irritated to see how young or old people may die by bleeding. So the blood vessels have been very important. Sure, the human being had also experiences by animals, they saw different type of vessels, and they saw the importance of this vessel system. I'm going to tell you now a little more about the human brain vessels. In contrast to many other organs, the human brain has a history. The history is the co-evolutionary phylogenesis, ontogenesis, and epigenesis. The human brain developed through hundreds of million years of co-evolution, numerous specific structural regions, and distinct functional circuits. Each topos in the brain is linked in the chronos in the areas and functions of the brain is directly related to a certain phylogenic, ontogenic periods of development. There is I don't like to enter the old histories, but remarkable are two persons. These are later by artists created pictures. Herophilos, now 2,300 years ago, he was born just here in this area, in Asiatic part of Istanbul, Üsküdar. Then he went to the new founded city Alexandria in Egypt. The Alexander Great created many cities in Near East and even in Central Asia, and one of the most productive city and center was the Alexandria in Egypt. Herophilos, and then another Greek scientist, Erasistratos. They worked together, and they have been fortunate also to have the chance to go to the areas where they saw how the expert Egyptian doctors, not doctors, specialists, made mummification of the wealthy dead people, and they saw how the organs are built, and they had a chance to observe many anatomic informations. And then they are actually fathers of the modern anatomy. Unfortunately, we don't have any drawings, any publication in our hand. But later on, especially Paulus von Eginata is another Greek man. He gave in the 7th century full information about all these time periods. So we are informed about these people. And I don't like to enter more about this both founder of the anatomy, neuroanatomy. It's a big jump, almost 1700 years later. From Holland, Dutch, came the Vesalius, and interested on medicine and on anatomy. He came to Italy, in the Bologna, Padua, Pisa, Venedig, because the Pope was allowed to make the autopsies. Before, it was forbidden in many cultural centers in the world. But it started, and then he was also another pioneer. He died in a young age at 50, but he gave excellent first-time books. He was very critical towards Galen. Galen was born in the West Anatolia, in Bergama, and he was a great medicine pioneer and surgery. He was trained in Izmir, then later he went to Rome, was the doctors of the emperors, and he made a great contribution. But later on, he studied on the animals. And Vesalius made this section on human cadaver, so he found some 200 error by Galen's anatomy. And if I look to the picture of great Vesalius, I can find also some not correct drawings. There are a little mixture. Next. Since that time, is a Renaissance time, there are at least some hundreds of great anatomists. They made a great contribution in Europe, later on also in Canada and in United States. And I enjoyed very much to found the books of Gustav Retzius, professor of anatomy in Stockholm, Sweden. He published several monographies about the human brain, then brain of the apes, and then he published also 2 large volumes about the systemic system. Is unique, and very precise information are there. I would recommend to a young colleague to find in libraries the books from Professor Retzius. It's a base information are there. Now to come to the vascular organ, which is very special, as I said at the beginning. The differentiation between arteries, capillaries, and veins, we know now together as clear knowledge. The interpretation of systemic cardiopulmonary and distinct central nervous system hemodynamics, clarification of the biology of the blood and lymph organs, elucidation of vasomotoric system, and of the enigmatic blood pressure, even nowadays, required centuries of intense investigation to achieve effective knowledge. The history of medicine presents us an impressive cooperative but also a controversial evolution of concepts and convictions related to vascular organ and unique functions. This is actually all related to other organs and all other convictions. It is good to have critics. Now, the vascular system in general and the neurovascular system in particular disclose anatomic, embryonic, histologic, genetic, physiologic, pathologic, medical, and surgical fascinating aspects. The neurovascular organ evolved into phylogenetic, ontogenic, infantile, adult, and elder age stages, stepwise. It is a heteromorphic and heterofunctional open system with a unique capacity to fluctuate and adapt according to focal and regional requirements of blood supplements. If there is a need, new vessels are created. This is unique. I like to recommend to young colleagues also the publication from Marin Padilla. He's a Portuguese originated, but he's working in New York as embryologist. I met him on a meeting, neurosurgeons, and then I enjoyed his presentation about the development of the brain vessels. I was very impressed, and I asked him, please give a chapter for us. So in the volume 3B about the AVMs, he gave, no, sorry, in 3A, he gave an excellent chapter how the meninges, the brain tissue in the vessel developed at the same time in cooperation, and then we had to find out this super architecture, a unique architecture, and I will tell you a little more later. Here we have, before I started the arteries, I'd like to show here the venous system is the much important also because it has enormous richdom. There are more veins in the brain than in other organs. And this is now well examined, but we are thankful to the publication of one Chinese colleague from Shanghai, as I remember, Yung Peng Huang. He was from Shanghai, and then he went then via Kyoto to United States in Mount Sinai. He was involved in neuroradiology and remain in neuroradiology, but he gave us the best information about the anatomy and also embryologic, the development of the venous system in the brain. Here we have him here on the nice picture. In development, interestingly, since Vesalius, we have another Dutch scientist, Friedrich Roche. He had the idea to inject into the vessel wax with color and then macerate the tissue. As you can see, he succeeded some 300 years ago. Such a perfect architecture of the vessels, unique, 300 years before. He was invited for many centers in Europe and showed his work. And this was stimulating. Another thing I like to show you, this impressed me, visiting a neurosurgical meeting in Florence some years ago. We had a chance to visit the Museum La Specula. In this museum, you can see here, this is a model, it looks like a living person. And everything is minutiously, precisely prepared from wax. And this is a Clemente Susudi. And it is an old tradition in Italy. They started also before, but in anatomy, Susini was the master, was helped by great scientist and anatomist Fontana, and they created incredible number, 2,000 each organs in detail. I was so impressed to see how the brain arteries can be seen here. You see on neck the carotid arteries, and then in brain is well, and also in the spine. 2,000 preparations are there, and if you have a chance to go, or maybe the Chinese companies will visit this museum and make some picture and give such educative lectures like this lecture now here. At that time there was no X-ray, no photo, no movies, no videos, nothing. These wax figures have been very important. So it was also made another series in France for Montpellier University, and then Vienna, and one was in the New Orleans in USA. This is from wax. It's well kept, not destroyed. Now, this was time period until 1895. It was not possible before, just 60 years before it started with the photography, first steps. And then Röntgen, German physicist, discovered X-rays. They can go through the tissue and see them inside our body, the structures, the bones, and later on other organs. This was made by him, by a person. You see the entire body skeleton on living person. This is the new area, the visualization area, first steps. 1895. And here is the Professor Harvey Cushing in Johns Hopkins Hospital. He was also a genial person, and he's the founder of, he was general surgeon, but he was more interested in the neurosurgery and was separating neurosurgery. And he used also 1 year later after the discovery of X-ray, he got a patient, was shot from backside with pistol, and the project was in the cervical spine. He operated this female and helped her on, but on X-ray they could see very well where is the projectile. And this was also introduction of the X-ray in the neurosurgery. And we see here many gentlemen, just few. The Guggenheim, the Oppenheim is in Berlin, is a neurologist. He supported very much Professor Krause. And Professor Schuller is in Vienna. He's a radiologist. He wrote an excellent books about the bones in our head, on the differences, etc. Fantastic book. He was a pioneer. And the next man is the Dr. Professor Walter Dandy, co-worker with Professor Harvey Cushing in Johns Hopkins. He came to the idea to give in the ventricular system in the brain air, because he saw by ruptured intestines the air was in the abdomen. He got the idea. So we had a ventriculography since 1918. And then we have the Leesholm, he developed better X-ray apparatus, and then we have the Sicard, French radiologist. He made the spine and myelography techniques. And here, two Portuguese experts. We have here Professor Muniz, neurologist. He got Nobel Prize for these discoveries, but not for what he made it. He made it first in dogs angiographies and later on human. But he was not the surgeon. Here is Dalima, Portuguese neurosurgeon. He was the man who made the angiograms. And they introduced the cerebral angiography. The first picture of brain tumors and brain vascular malformation came 1934 around, and published by Moniz and Dalima and Dot in Edinburgh in Scotland. I came to neurosurgery on January 1953. And Dr. Crimeville is a very excellently trained neurosurgeon in England, in Oxford, in London. Then he came 1936 to Zurich and founded neurosurgery in Switzerland. He was very disciplined person in his thinking and working, in how he was a meticulous and carefully surgeon. I spent with him 40 years. He was interested what I made it in my training, and I told him I learned a little neuroanatomy dissection. He said, good, then you should now try to do something different. Can you puncture the carotid artery and vertebral artery through the skin? I said, I will try. And next day we started, and I was, you see here on picture, I didn't ask for this picture. On the background is a nurse. The sister of this nurse did like to have the picture from her. Now she was behind the apparatus. We had a installation behind this X-ray apparatus. So there was 6 X-ray films. She had to pull out the cassette. I punctured the artery with a needle and then injected. By injection, immediately I said, go, 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 go. In 5 to 6 seconds, she pulled out 6 films. So this is the time in adults where the blood flow runs. And in children, maybe 4 seconds. We made a serial angiography, and also we had here very unusual apparatus. We made a first series, and for the second series, we changed the axis of the X-ray camera 5 degrees, and whether horizontal or vertical. And then we got a stereo picture. In the picture, we could put left side and right side. In the middle is a mirror, and you can adjust the mirror axis, and then you related your own eye positions, and you could see the vessels like you are sitting in the brain. We saw the arteries at the beginning, then full, and then the capillaries, then we saw the veins, and then full draining system. Three-dimensional, from right on, or from left, from front, from the back side. So it was a perfect orientation. And our experiences, I made almost 12-year angiographies. At that time, there was no computer tomography, no MRI. So first was an electroencephalography made, and related to the symptom, on AAG was made a one-sided angiography, or both sides, or four-vessel angiography. Altogether, some 9,000 angiograms were made and put it in these two publications. This blue one is the vertebral basilar system, and then the green one is the carotid system. My interest was mainly to study the variation, individual variation of the arteries and the veins. You see here, if we could sit here in front and move the mirror system forwards or backwards, or also a little move around. It was a perfect situation. I did like to present in this book also three-dimensional pictures, but the company said this would be very expensive. So unfortunately, we couldn't make it. Now, being interested of this cerebral angiography, I studied also the special anatomy of the arteries and discovered there are some 10, 12 different segments which are in architecture a little different, and also there are vessels, veins around the arteries, but intracranial they are not close to the arteries. So, involved on this special anatomy, we found the brain arteries are different. They have a different outer layer, adventitia, less collagen fibers, lamina externa doesn't exist, media muscle is also gradually getting smaller. Then nerve innervation is reduced. In vascular activity also, vasomotor activity reduced. Endothelial regional change. And then very important is vasa vasorum. Vasa is vasa vasorum. Like the coronary arteries, vasa vasorum help for the metabolism on the arteries, on body. But in the brain, they can help only outer layer, outer 1/3. And from inside, it's coming from the lumen, from inside. In the brain has no vasa vasorum. And a lymph vessel was called missing, but the new discoveries show they have a very fine lymph vessel around the brain vessels. In studying the brain arteries, it was clear the brain arteries are not end arteries, they're not end branches like in a tree. At the end, they come together. They get smaller, but they get connected from one hemisphere. They have a very special connection system. And we have 4 main arteries bringing per minute 5 to 600 cubic blood to the brain, four vessel, carotid and vertebral. And then there are also connections to the spinal arteries. So we may have a occluded vessel in one artery or two, still the patient may have no symptom, or 3 arteries, no symptom. When 4 arteries can get occluded, and still the patient has no problems because the collaterals from spinal arteries goes to the brain. And Professor Kikuchi, who was trained with us in Zurich, he discovered, visualized in 2 patients in Kyoto such a situation, 4 vessels occluded, spinal collaterals. But it is not so simple. We may have survived with occlusion of 1 or 2 or 3 vessels, but sometimes one artery narrowing, stenosis, or one branch of an artery make problems because the collateral system doesn't work. In children, it is said they work better, partially. So for the young colleague, please think on this. We still don't understand the function of these brain arteries. They have collaterals, but the function is not secured. For some reasons, it's partially well studied, but still not well proved what's going on. So this is very important for us, in which cases of an occluded vessel we need to help. Here is another picture of a brain arteries, on here red. We may have a occlusion in one artery, okay, but there is a one connection here, you see, main connection. So it can be helped from the other side. But there are small arteries here. They are some way end arteries. If one of these arteries close, then it's a big trouble because they vascularize, support deep center of the brain. And then it can be very negative for the patient. Now, we started to study this system and found also for the young colleague they should realize we may have a vessel, not only 2, 3. In the middle, the third anterior cerebral artery can be dominant in vascularizing both hemispheres. So any problem to this main artery can be very sequential. Big problem may arise. Now, as I said, the phylogeny I couldn't find in properly publication about the phylogenic development. But in ontogeny, there is an excellent publication. We see in the person within 9 months how the vessel system change and find final condition like here, as you know. And then here, the development of the arterial system and venous system. There is in each book, these pictures are presented. And it is originally made by an artist I like to show her. This lady, her father was a teacher, and she had a talent, as a child, talent to drawing, and the father sent her to New York to be an artist. But she discovered differences. And so I like to tell, she made 1948 an excellent monography about the embryology. And this book, this picture, what you saw from arteries and veins, she made herself. Great artist. But unfortunately, she died very early on a cancer. Now, she started in New York with the art school, but changed immediately to Johns Hopkins Hospital, to this center. This is the artist center. And one German artist from Leipzig was taken from the anatomy and gynecology professors to Johns Hopkins, Max Brödel. He made this center, as you can see here on the right side. The artist, he trained almost 400 young people as artists. Left side, with the neurosurgeon were trained in this laboratory. And Max Brödel also trained Cushing. Cushing was talented to drawing. So the old publications from Cushing and from Dandy are excellent, or from other discipline. They made an excellent contribution, Max Brödel and then this lady which I showed you. And here is the Max Brödel in elder age. And he said the learning experience would be incomplete without self-investigation. The artist must know that his subject so truly that he can shut his eyes and coax into existence a mental picture, a great clarity, complete in every respect. This means, as you saw on the right down, the pictures are not just photos. They are animated picture. You see, the photo on film and all the MRI and all fixed. The artist, we need the artist because the artist adds from his memory and his imagination, his experiences, informations. So we have an animated picture, and these are very essential. And this was the Max Brödel school. I was planning to come back to Turkey in 1960 around, and then my teacher and chairman, Professor Cranby, said, no, we have to publish first, and you have to work on this book. And then 1962, we get a cardiovascular surgeon, Professor Ake Senning from Stockholm. He was an engineer also, and he started in Zurich open heart surgery. On children, he repaired the valves, heart valves, and very few cases happen. And in this case here, what you see, the arrow is so small, and I have trouble to show immediately. But Mr. Ali had showed you. A 17-year-old young lady, by awakening of after heart surgery, she didn't move the right side and she couldn't speak. And then I made the angiography and saw here one artery, so-called central sulcus artery. And is very responsible for the pre- and postcentral gyri, important for the movement and for the sensory. And I showed Professor Senning and said, there is here an occlusion. He got very upset and said, oh, you should go and operate this immediately. And my answer was, yes, sir, but I have no experience to do this. And then I can not imagine we don't have that much small needles and suture material. We have to learn. Thank his insistence, I had to go to learn somewhere microvascular surgery. And it took a while until we found a proper center because they didn't exist. Finally, we found in Burlington, Vermont. Now, on the microscope, I'd like to show just important information. One another Dutch businessman, successful businessman, he had an interest on science, on nature, on biology, and he developed himself a special microscope. Imagine in the 17th century, he made that, he melted the glass, and the drop of glass, they have been like the lenses. So he created lenses magnifying 100 times, 200 times, 400 times. So he could see the red cells. He saw first time brain cells. He saw the spermian. So he was a great discoverer man. But interesting another point. This Italian technician, Giuseppe Campani, in the 17th century, he created this microscope, but it could be used also as a telescope. And then you could see here he is trying to help to see the wound on an injured leg. And the nurse give the light by candlelight. And this was, imagine, it took another 300 years before really an operating microscope was created. It is the society must get ripe and demanding, and for few cases the industry cannot produce, and so the discovery remain unrealized. Here, I came in 1965 in October to Burlington, Vermont. On the background you see Professor Donahue. He was interested to do vascular surgery and working on rabbits' femoral arteries. And here is the head nurse, scrub nurse, Jackie, her surname. Professor Donahue had time one mornings, 3 hours to show me how we can work. But my teacher was this lady, Mrs. Rogers. She was patientful and very strong teacher, and she observed all what I am doing there. And we started first by a rubber tube. Later we started with a rats and then rabbits and then later on dogs. And I worked 2 months on extremities. Another remark, the brain, not brain arteries, the vessel surgery was started in the 18th century, 19th century laboratories. And here is Professor Alex Carrel from Lyon in France. He went first to Canada, Montreal, then went short time later to St. Louis and worked with Professor Guthrie. He was in Chicago physiology professor. He had a good laboratory. So he learned by him the first steps of the vascular surgery. And he's a genial person, and he had ideas to do also more and more and more. And he made an organ transplantation on animals successfully. Professor Carrel and Guthrie. Professor Carrel became the Nobel Prize, and his principle was to have this 3-point fixation and then repair with 10, 12 suture. I never used this because I put inside a soft tube, and then the last moment I removed. Here are the paintings. Dr. Donaghy. With Dr. Donaghy was working Dr. Julius Jacobson. He was cardiovascular surgeon from New York, appointed to Burlington, and for a pharma company, he should study what happened if the carotid arteries ligated, etc., and then sutured again. His assistant from Argentine, Dr. Suarez, saw in corridor in laboratory size microscope. Said, "Sir, can we use the microscope?" He said, "Okay, we do this." And then I will show you what he made it. So it started repair of the vessels on the microscope. They came down to 2 millimeters. And here is Dr. Harry Banke. I visited 1966 some 10, 12 centers in the United States, mostly plastic surgeon, cosmetic surgeon, vascular surgeon, and they have been interested to make a precise anastomosis. And Dr. Banke showed me one monkey and said, "You see, on this animal, I made a transplantation between thumb and big toe, and it works. And this is important." I was very impressed from his work. It was very precise. But we lost him, unfortunately, on a car accident, by motorcycle accident. Now this is the preparate, what you see here on the upstairs, upper corner. End-to-end anastomosis made without microscope. Here with the microscope. This was given to me by Dr. Jacobson in April 1966. I like it. I started to do brain artery surgery. I insisted, saying, "Dr. Donaghy, sir, I have to do some help for the cardiovascular surgeon in Zurich." So we started to operate first on the basilar artery. Approach was transcervical, transclival, and a small opening. And I made even on this case a patch. I took this artery some 1.5 millimeter, and at that time we didn't have a fine needle and then suture material. And you see here it worked well. And then I like to show this dog. This was the dog. He survived very well. It's interesting, as I met him first day, he was barking. But later he got a good friend. I walk with him every day around the laboratory. Now, here is the first case. You see the brain artery in 1 millimeter. It is smaller than 1 millimeter. The point is, the artery is not on the surface, but covered by arachnoid and arachnoidal fiber system, like a spider network around the arteries are very fine fiber systems. So just 1 centimeter opening of this segment needs real time on patient. You see, I made it well. You see the gyral area seems normal out, and I made a patch. This worked, and then I said, Dr. Darnay, sir, the new area neurosurgery should start. And you see here end-to-end anastomosis, and here is a graft, double, just exercise. And here extra intracranial bypass on a dog. This was possible thanks to bipolar coagulation technique of Dr. Mallis. Leonard Mallis was in Mount Sinai Hospital and very close friend of Yung Peng Huang. And he developed this operate bipolar coagulator so we could make just a small point bipolar coagulation. I used at the beginning forceps for watchmakers. They are 6 different sizes, 0 to 5. By 5 is the end is like a needle. So you can make just 1/10 of a millimeter small coagulation. So we could keep the area very clean. Unfortunately also we've lost Len Mallis early. And this was a great help. Microscope and bipolar coagulation. And we developed, later you see the series, almost 30 different lengths and tip size. You can make it much more, maybe better. Okay, because we are working on brain, on surface, but we go to the cisterns down, sometimes 10, 12 centimeter in depth. So we need special length. Now, 1953, there was a revolution in the optic system. Dr. Littman succeeded to produce this OPMI-1 microscope with electricity, and you could move, and this was good. But we found we need in neurosurgery much higher mobility, and we developed counterbalance system and with electronic control. with a brake system to stabilize and to move. And you see me here sitting on a hydraulic chair and also armrest. It is very important to have forearm and hands stabilized, because 10 minutes you can stay in the air, but 2-3 hours you will start to have a tremor. So this hydraulic armrest is also mobile, can you move 360 degrees around, is very essential. And the microscope is now advantage between ocular and objective short, and it was a problem of a heating because the ocular get after a while foggy, so we started put cable and make a heating, light heating. And then here the mouthpiece, if I push here, it released the brake, and I could move with my mouth microscope, because if there's a 40 kilogram counterbalance, it is easy like a feather if it's a good balance. And now, we discovered later that the astronomer for the telescope use also heating system like this. I put here the name of the company. And we needed also temporary clips to stop the blood flow in the arteries. Just few minutes. And originally we made it just 4 or 5 clips, but later they created 180 such a clips in length and fine, and we made also one very small for small vessels. Now, another essential part is for the microsurgery is to have this cotton patties. They can be very small or large. They keep the area clean, and I will tell you why. Later I will show you. Here, 1967, in January, I came back to Zurich, and then we waited for a while until a case came with a good indication for surgery. A young man, 27-year-old, not smoker and healthy, but he got an acute stroke, but temporary. He was full recovered as he came. And I said, look, you have the inferior branch of the middle cerebral artery is occluded. You may have more trouble. He accepted, and we see here yellow sclerotic part of the artery of the inferior trunk. And then I opened it and then made some 20 single suture. It was well opened, you can see angiographically. How come this sclerosis occurred in a 27-year-old person? He's not a smoker. We all react as tobacco make, but there are other genetical factors we don't know what. This was the beginning. Now, this surgery was made also by other surgeons, neurosurgeons. I put the name here. And without microscope. But the point is, these arteries are in the fissure and in the sulci. And they are covered by arachnoidal fibers and the membrane. We can open the membrane easy, but the arachnoids are so small, like the small vessels. It's better to do it under microscope. None. The point is here. These operations on patients with occlusive intracranial vascular disease have been approached with great apprehension and hesitation because the indication for operation in such cases has not been delineated. Now, we don't have any clear method to show us whether this person has now the symptoms and improved, whether he will get again, when, and whether light again in a small stroke or big stroke. It is unclear. We have no method to control the function of the collateral system. In individual case, there is no precise method to determine whether spontaneous recovery or repeated attacks with progression of the disease will occur. So I operated altogether only 7 patients with middle cerebral artery. And then Professor Fisher in Boston is a neurologist. He was very interested on problem of the blood circulation of brain and stroke problem. He said, it is even conceivable that someday vascular surgery will find a way to bypass the occluded portion of the artery during the period of ominous fleeting symptom. Anastomosis of the external carotid artery of node of its branches with the internal carotid artery above the area of the narrowing should be possible. Nun, sorry, I couldn't read well, but it declared clearly, once a day, should be made a bypass. And this was made. Worringer, neurosurgeon in Colmar, French, and Kunlin, vascular surgeon in Paris, came together and made a first anastomosis 1962 around, anastomosis between external carotid and intracranial carotid, a complicated way. It was very successful, performed, but the patient got a pneumonia and died. So this was unfortunate. Now, in 1967, October, one patient came with symptoms. He was at that time 57-year-old gentleman, engineer. He said if he turned his head to the left side, he get a weakness on the right side and fell down. And I made him, myself, the angiography. As you can see, the right internal carotid occluded, left also occluded, and the right vertebral I couldn't puncture, but the left side, you see, from the left vertebral, entire brain is filled. There are also other collateral for the brain circulation, and transorbital or from backside, from occipital artery, but this is the main way. So this was the situation of this gentleman, 3 arteries occluded, only the left one open. And then we see also sometimes only a segment of carotid artery can be occluded and hinders the collateral system working. sorry. I said to this gentleman, I know now technique I could help you making an extra intracranial bypass. He was enthusiastic. He said, oh, okay, we do. And we made it. You see here is on the surface of the right temporal area an artery. And you see, here is the artery, and then here is the superficial temporal artery. And then we made anastomosis. It was working. And you see the collateral. This was the first case on a human case. It works, bypass. You see this gentleman here. He's standing also on his left leg. Now, short after, it came critical remarks. They made a studies. The negative results of this study no longer allow us to believe that bypass surgery is an instrument of consequence in the prevention of the stroke. But we have situation like in this lady's case. She was at that time 18-year-old, had no bleeding from this giant aneurysm of the internal carotid bifurcation, but she began to develop left side weakness. I offered her, we can see whether we can put a clip, but it was a very large base, and I put ligated the internal carotid artery distal to the anterior carotid artery and made an extra intracranial bypass. She's still alive. This was 1968, and she's doing well. She's married, had children. So this is one possibility, and it can be used by aneurysm and by tumors. And then this disease, this is discovered by a Japanese colleague in 1957 called Moyamoya disease. And interesting here, the vertebral artery filling not only the cerebellar and cerebral, also in the mesencephalic area, enormous micro arterial system, increased one. And in this case, Professor Curie had both sides, anastomosis made it. And you can see it is both sides made and very well. And this congestion of the microarterial disappeared. This phenomenon I don't understand. What type of a micro collaterals are there? This is not well clear. Now, this can happen to the children. This can happen also to the adult person. And it's happened 1972. We get a family coming from Belgium with a 6-year-old boy. He had some mental problems, and then some seizure type, and we found he has Moyamoya disease, bilateral carotid. In my knowledge, bilateral vertebral, I never saw it. So I made this 1972, and Dr. Kreinbill published this 95. This is for the colleagues' information. This was the first case Moyamoya bypass, extra intracranial, because it is very difficult the vessels are so much smaller and need more patience. Now, coming back, the point is here academic. We are mixing two clinical conditions. One is the full stroke, ischemic stroke. The population notice either only arm or arm and leg, and also speech trouble or completely lost. Or they can be only short symptoms, problem with the eye, or some weakness a little, short time. We call this temporary ischemic attack. In these cases, if the angiography show some occluded segments, 1, 2, or 3, we need bypass. But if there is a full stroke and hemiplegia, aphasia, and the CT and MRI show us infarct without hemorrhage, first infarct, later they may have a bleeding. So the stroke is another disease. The circulation problem is different. And this was interesting to tell you here. 1628, William Harvey, English scientist, he visited and learned in Italy. He got information about the vessel system, and he first time presented the blood circulation of body. And this was also published in a book, monography, 1964. There were pictures from great English architect Wren. So this is now well known as circle of Willis. So connection between the both in anterior cerebral and the posterior cerebral to the carotid system. And then Malpighi also discovered the capillary system, so it was complete knowledge. But it is some way forgotten one Swiss physician, Wepfer, in Basel studied, he wrote 1685 a voluminous book I had in my hand from the library in Basel. And he described in this book precisely the circle of Willis, but there is no single picture. So we should mention him also correctly. Here is a Willis and the picture of Wren, and then later on drawing how we. Now the discussion. You see, this picture is made in Kenya, Nairobi. There was a surgeon who was trained by Dr. Senning in Zurich, heart surgeon. Then he returned home and he discovered this case. You can see in internal carotid artery is stenotic before bifurcation and poor branches. But the nature created from extracranial occipital artery a connection to the cortical artery. So the nature made actually the first extra intracranial bypass. I never saw such a case, but Professor Ture told me he saw some cases. I don't remember. Now another question arises: if the brain needs blood, we need also a better extra intracranial bypass. You can take a saphenous vein, or you can take an artery and make a free transplantation and connect to the carotid artery. This is not my opinion. I tried to do this on dogs, it didn't work. And I said superficial temporal artery is 1.5 to 2 millimeter size, but if the brain needs blood, it will get larger, and this is the case. This extracranial arterial system is a good supplier for the brain circulation. I published in 1968 this microvascular surgery. This is now the new edition. If the colleague would like to see a little more detailed information about the bypass technique, we will find there. Then later on, I published this second book after I had some 3-4 year experiences in surgery. Here are the T-tubes. And then this is a company, unfortunately, it's closed. They cannot, there are very small, less than 1 millimeter tubes, or for the carotid artery, larger tubes. We can cut the ends a little shorter, and you don't have to put that much in entire length. So, because the blood circulation should not be interrupted. Even if this only few minutes, 5 to 10 minutes, if you put such a tube, you can work in half an hour or 1 hour quietly, properly. Now, one more. I like to I operated only few cases carotid arteries because they have been operated in the general surgery. And so they went well, what I made it. But here I like to show this publication in European Journal of Vascular and Endovascular Surgery. You can copy here. Is an excellent summary what was made in laboratories and later in human, if you like to read it. And then there is another publication here from Journal of Vascular Surgery, 2014, from Friedman, about the topic who made the first carotid end arterectomy. And interesting, they made the first ligature and then end-to-end anastomosis to the from the external or from direct internal to internal. And Debicki made a just incision and remove the sclerotic part and make the suture. So there is a discussion now who was the first. First was made it in Carrea in Argentine, yeah. You can read this in this publication. I hope I gave a little information for the young colleagues where we are still in big problem. Still, we don't have a very proper method to measure the brain capacities, especially hemodynamic capacities, whether it will recover itself or is a big danger is there. And this is the main problem. Surgical technique is there. We can go down even to 0.5 millimeter size. But the problem is a good indication. I heard from Professor Ernest Niemi, one Chinese neurosurgeon made already 7,000 extra intracranial bypass. I like to read the results, how it looks, and what indication was given, etc. Would be very interesting.
Yes, but due to some technical issues, he cannot join us today. Now we'll move to our next speaker, Professor Rashad Abdelghani. Professor Rashad is a well-known consultant neurologist, and he's the chief of the Yemeni Neurology Association. Dr. Rashad will talk about stroke and the importance of stroke unit. Dr. Rashad, you can start.
السلام عليكم. بداية يسمحوا لي أن أتقدم بالشكر والتقدير إلى الجمعية اليمنية لجراحي المخ والأعصاب لهذه الدعوة، ممثلة في الهيئة الإدارية واللجنة المنظمة، وعلى رأسهم الدينامو الدكتور أحمد الجرادي. وانتهزها فرصة لأهنئهم بهذا النجاح المتميز للمؤتمر اليمني الخامس لجراحة المخ والأعصاب. لن أثقل عليكم أنه وقت متأخر، ولكن سنحاول. أطلع فوق هذا ولا بعد لكم؟ أوكي. Management of acute ischemic stroke and the importance of stroke unit. As you know, stroke is a major public health problem. It is the third cause of death and the common cause of disability in adults. So I chose this topic, especially that the stroke day أو World Stroke Day كان يوم 29 أكتوبر ليس بالبعيد. نظرا لأهمية الستروك، منظمة الصحة العالمية أقرت أن يكون هناك يوم عالمي للسكتة الدماغية. لماذا؟ لرفع وعي الناس، البوبليك أويرنس about the stroke، حتى أنهم النيو نيم فور ستروك الآن هو البراين أتاك، to inform the public about the urgency of the stroke، على غرار الهيرت أتاك. بمعنى أي مريض يشعر بأعراض من أعراض الستروك اللي هي بي فاست عليه أن يسرع ويسعف نفسه ليتلقى العلاج اللازم. أنتهزها فرصة لأترحم لأستاذنا القدير هاني عارف، وهو من أعمدة الاتحاد العربي لطب الأعصاب، والذي كان له الدور الأبرز في إنشاء وحدات السكتات الدماغية في عالمنا العربي. This is my outline، ولكن I will be brief لأنه جيعانين أنتم والغداء جاهز. ها طيب،
قول بسم الله.
في صوت؟
الله. قول. غمض عينك، خرج لسانك، خرج لسانك، ارفع يدك لفوق، يدك اليسار ارفعه، ارفع يدك اليسار. أين يدك اليسار؟ يدك اليسار أين؟ أي منهن؟ هذه رجلك، هذه رجلك يا صاحبي. أنا اشتي يدك اليسار ترفعه، ارفع يدك اليسار.
طيب، what wrong with this patient الحاج محمد؟ What's wrong with him? What we can do for him؟ معنا طلاب صح؟ الفيزياء عنده وراثات هيمي فاريسز. ايش نوع الافاسيا؟ ها؟ No spontaneous speech, poor comprehension. So he has global sensomotor aphasia. بمعنى the dominant hemisphere is affected. طيب what we can do for him؟ هذا بيعتمد على depend on هل هو أسعف نفسه باكرا اللي نسميها therapeutic windows. therapeutic windows. الشيء الثاني هل we have يعني the availability of stroke care. availability of stroke care as you see here. يعني زي ما تكلمنا البوبليك اويرنس هذا مهم، ضروري نوعي الناس علشان تسعف نفسه باكرا لتلقي العلاج، وهذا يشتي كل سنه نعمل لهم بوبليك اويرنس. مع الاسف معظم اللي عندهم ستروك يجي لك اليوم الثاني اليوم الثالث، يروح عند الشيخ اول يقول لك يمكن يتحسن، ما يجي بالثيرابيوتيك ويندوز، وبالتالي نحتاج الى مجهود بالنقطه هذه اللي هي بوبليك اويرنس. emergency medical service transport. الاكيوت ستروك يونت هذه مهمه جدا. ستروك يونت والتي تحتاج إلى ملتي ديسيبلينري تيم، نيورولوجيست، راديولوجيست، نيرس، نيوروسيرجن، انترفنشنست. كل التيم نحتاجه علشان نعالج المريض. البوينتر اوكي. ذيس بي فاست عارف انها وهي اللي نعملها في الحملة العالمية في يوم السكتة الدماغية. طيب important of stroke unite. The best chances for recovery from stroke are given when patient will be treated in stroke unites. Stroke unit are specialized center with dedicated beds offering a multidisciplinary treatment of stroke by dedicated stroke team addressing the acute treatment as well as early rehabilitation and secondary prevention. Stroke unite reduce mortality and morbidity and disability through the provision of specialist multidisciplinary care for the diagnosis, emergency treatment, normalization of hemostasis, and prevention of complication and secondary prevention. The goal of Stroke Unite to continuously monitor parameters such as ECG, heart rate, blood pressure, respiration, oxygen saturation, temperature, and glucose in order to prevent and right complications. To provide thrombolytic therapy سواء كان تيشو بلازمين اكتيفيتور او اللي هي ميكانيكال ثرومبوكتومي. To identify stroke cause in order to provide a target treatment. To provide early mobilization and rehabilitation. To provide secondary prevention. General management of acute stroke. We should don't give excessive IV fluid, especially dextrose, because قبل يومين
John, do you hear me? Hello, John. Are you there? John. John.
Yes.
I can go on.
Please make me co-host and accept you, Dr. Sana, Dr. Sana Mercy, as a panelist. You take all the co-host privileges from us.
Okay, I can't understand you. Could you text, please? Or someone tell me what's going on?
Okay.
You want me to introduce you?
Yes.
Are you ready?
Let Dr. Sana as a panelist. He is attendance now. Make him a panelist. And we continue with Dr. Rashad. And after we finish, Dr. Sana will give his presentation, okay?
We will continue general management of patient with acute stroke. As we mentioned, take care, don't give excessive IV fluid, especially dextrose, because the patient will develop cerebral edema. The other point, you should not to drop the blood pressure. Don't drop the blood pressure because of cerebral blood flow will be decreased. The recommendation for treatment of blood pressure, if there is hyper or hypoglycemia, you should try it. Hyperthermia, أيضا الكاردياك monitoring, oral intake by mouth initially, oxygen if needed, والtemperature زي ما قلنا avoid hyperthermia. This guideline for treatment of blood pressure, I will go. طيب early management of ischemic stroke تتلخص بالرابid identification of stroke اللي هي السيمبتومز، وبعدين immediate emergency medical service transport، يعني اسعاف سريع to the nearest stroke center او يونيت. وعندنا الستاندرد كير اللي هي thrombolytic therapy. إذا المريض وصل, if the patient arrived with therapeutic windows not more than 4.5 hours, we will start tissue plasminogen activator altiplase. If there is a large occlusion of the vessels in the anterior circulation, we will go to mechanical thrombectomy, and the therapeutic windows is up to 6 hours. طبعا اول ما يوصل المريض نعمل له اسسمنت والاي بي سي المعروفه، ونعمل له emergent CT scan. طبعا اللي CT scan نيجاتيف فقط يطلع if there is hemorrhage. ولكن if you want to diagnose stroke in hyperacute stage, you should do diffusion weighted MRI. بعد الاسسمنت نحن نختار منهم اللي هم eligible for thrombolytic therapy اللي هي tissue plasminogen activators by LTPS، والثيرابيوتيك ويندوز تكون not more than 4.5 hours. We should do also non-invasive intracranial vascular imaging بالنسبة للبيشنت who has occlusion in a large vessel of anterior circulation like internal carotid artery أو anterior carotid artery أو middle cerebral artery. We will start with endovascular therapy and do stent retriever. طبعا الكانديديت فور thrombolytic therapy في inclusion criteria و exclusion criteria. inclusion criteria هي الاسكيميك stroke with clear symptoms of neurological deficit. يعني هنا ممكن نستثني اللي عنده ماينور، اللي عنده TIA ما تعملوش thrombolytic therapy وانت مش متاكد انه هذه TIA. الاكسكلوجن كريتيريا كما تعرفون اي هيموريج سواء كان انتراكرانيال سباراكونيويد active internal bleeding recent intracranial or intraspinal surgery bleeding tendency current severe uncontrolled hypertension. additional exclusion criteria إذا المريض عمره أكثر من 80، إذا الستروك more severe ولا NIHSS more than 25. History of diabetic and prior stroke, taking an oral anticoagulant, altiplase. الآن الكانديديت for mechanical thrombolytic therapy زي ما ذكرنا if there is occlusion of a large cerebral artery in the anterior circulation. الكريتيريا for this الثيرابيوتيك ويندوز ممكن تمتد حتى 8 ساعات على عكس اللي هي تيشو بلازمين اكتيفيتورز اللي هي 4.5 hours. ويكون في عندنا اوكلوجن في الارتري ولان اتش اس اس يكون يساوي 6 او اقل. الريسك اوف ثرومبولايتيك ثيرابي اهم ريسك هو الهيموريج. في بالنسبه للالتي بيز حوالي 2.8%. المورتاليتي لا تختلف كثيرا عن البلاسيبو not more than placebo group. نجي للريسك او السايد افكت اوف endovascular therapy اللي هي الهيموريج intracranial hemorrhage due to vessel perforation or stent retrieval وممكن يحصل systemic bleeding وممكن يحصل bleeding at the site of catheter وsecondary catheter infection وdeath. الهوم مسج هذه رسالة this presentation واللي هي أهم نقطة. How we can improve outcome. What we need for improving outcome, we need the following: public awareness, availability of stroke care, emergency service, and management. Acute stroke unite with the management, including implementation of reperfusion therapy and rehabilitation. Thank you very much.
Thank you very much, Dr. Rafat. That is very mature and valuable information. Next, we have Dr. Sameh Al-Mousi from Egypt. Dr. Sameh, are you there? Dr. Sameh, can you hear me?
Yes, I can.
How are you doing? We need Dr. Sameh. Dr. Sameh?
Do you want me to introduce you, or what do you want me to do?
See him in the panel, but I do not hear him. I cannot hear him. Dr.
Oh,
Sameh?
can you hear me now?
I am here. I can't hear you well. Do you hear me?
Yes.
I hear you. Okay. How are you, Dr. Sameh?
Okay, can I share my screen?
Sameh is a
Yeah, hi,
consultant.
Sam. Hi, Sam.
Dr. Sameh is a consultant neurosurgeon and president of World Federation of Spinal Endoscopy and the co-chairman of the WFNS Neuro-Oncology Committee and co-chairman of Central China Neuro-Oncology Forum and executive committee member of ONS and CNS Conjoint Tumor Section. Dr. Sameh will talk today about microsurgery or endoscopic lumbar spine surgery, critical scientific analysis to solve the dilemma. Dr. Sameh, please, you can go on.
Hello, everyone. Do you hear me?
Hello, Dr. Sameh.
Hello, Dr. Ahmed. Do you hear me?
Yes, I hear you.
Okay, I will start showing you my screen.
How you doing, Victor?
I'm fine. I'm fine, John. Thank you.
دكتور سامح.
I am here. Just give me 1 minute. Try
Okay.
to share my screen. Sorry for this delay.
Did you start screen sharing, Dr. Samah?
I am trying. Just give me one second. 1 minute. Zoom can't give me access to my files. I don't know why. So you just give me one more trial.
If you need more time, we can start with Dr. Victor until you, as you like. Dr. Saleh, your internet connection is very, very low. So maybe this will be an issue. I think Dr. Saleh is not with us anymore. But I will try to contact him by WhatsApp. Otherwise, we will start with Dr. Victor until Dr. Saleh come back to the Zoom.
Hello, Professor Ahmed. How are you doing?
How are you, Dr. Victor? How are you?
Fine.
Good morning, Victor.
Hello, John. How are you doing?
Good, very good.
You look very strong, John Bennett.
There you go. He's lifting those weights. Okay, so what is the plan there, Ahmed?
Dr. Victor, how are you? I hope you are good.
Yes.
Until we figure out what is the problem of Dr. Samah, we can go on now with Professor Victor. Professor Victor Hugo Perez is a neurosurgeon and a neuroanatomist from Mexico City. He is a fellow in skull-based surgery at the Detroit Medical Center at 1995 and fellow in spine surgery in Mexico City, and former member of Committee of Neurosurgical Anatomy and Committee of Award for Young Neurosurgeons of the UFNS. Dr. Victor will talk today about surgical anatomy of spinal cord vasculature. Dr. Victor, please, you can start.
Thank you, thank you. Give me. Okay. Can you see it, all the screen?
It's not full screen yet, Victor.
It's not the roof tree.
Put it on presentation mode.
If you can
Oh, you fell off there.
Now it's okay? Now
Yes,
it's okay?
yeah, perfect, Victor, perfect.
Okay, thank you. Thank you for giving me the opportunity to speak about vascular anatomy of the spinal cord. So I'm going to speak about neurosurgical vascular anatomy. Spine and vascular anatomy are a kind of knowledge, very important. And knowing this surgical anatomy of the spine and spinal cord allows us to be more precise and accurate in our objectives in vertebral column and spinal cord surgery. Here we have a picture about dissection and exercise to put some screws into the lateral mass of the cervical spine. Here this rostral and caudal. Rostral and caudal. And as you can see, after removing laminas, we can see this dissection. This is dura mater. And let's go to the other picture. And here we have opened the dura mater, and we are looking for the spine nerves. This is radicular nerves in the cervical segment, and this is dentate ligament. This is posterior aspect of the cervical spinal cord. So I'm going to show you this info about the artery of lumbar enlargement. This artery was identified between T3 and L2 in all 50 specimens. And the artery of cervical enlargement was identified in 84% of specimens. At least one dominant anterior thoracic artery distinct from the artery of lumbar enlargement and the artery of cervical enlargement was identified between T1 and T11 in 47 of the 50 specimens. This was sent to the American Journal of Neuroradiology and was published in 2022. The title of this article was "The Dominant Anterior Thoracic Artery of the Spinal Cord Data." And then I'm going to show you what we are doing here in Mexico City. This is a thoracic segment of a spinal cord, and this is very fast. This injection of this artery, these arteries are very, very thin, and it's not easy to put some dyeing in there. Again, injection of these very small arteries in the thoracic segment. Irrigation of the thoracic segment of the spinal cord. We found the dominant anterior thoracic artery data which was identified between T1 and T11 in 94% of the specimens. So this artery is very common in that segment. This was the most frequent site of the level of T4 on the left side, and the average diameter of these arteries was 446 microns, with a range of 270 to 759 microns. At least one data was evident in 94 of spinal cord specimens. A single data was present in 66% of the specimens, and two data were identified in 26%. Three data were identified in a single specimen, all arising on the left at the level of T3, T7, and T9. Let's go to see this another injection of this artery. These arteries are very thin, and most of them could be broken at the moment of the injecting this color, but like this and this. Then after, we can see the beauty of this injection of the spinal cord. This is a lumbosacral segment, the conus medullaris, and the posterior spinal artery, and the nerves. Like this. Here we have a posterior aspect, anterior aspect. Here we have the Adamkiewicz artery, conus medullaris, and this is an anastomosis, or with the posterior spinal artery. And this is a great posterior radiculomedullary artery, this one. Is greater than the others one. And here another beautiful picture looking the lateral aspect of the spinal cord. Here we have the anterior aspect, posterior aspect, and here we can see a communication between anterior and posterior, the conus medullaris. These are small arteries coming from the radicular nerves. Another picture for seeing the posterior aspect of the spinal cord. Here we have two arteries, each in one side of the posterior aspect of the spinal cord. So look, this great posterior vein, spinal vein in the posterior aspect. So it was Albert Adamkiewicz who almost 120 years described this artery, Adamkiewicz artery. These are some drawings that he made in that years. And here we have two vertebral arteries with this technique, using this kind of material to inject the vertebral arteries and the anterior spinal artery. Now, with modern techniques, we can do this injection of vertebral arteries. Here is a hypoplastic vertebral artery and the contralateral vertebral artery. These arteries are giving rise to this anterior spinal artery in the cervical segment of the spinal cord. In this picture, we can see the all the rachis of the spine. In the next, once we remove this spinal cord, and then after we inject veins and arteries, we get these beautiful injections in order to see in a clear way the anatomy, vascular anatomy. Here we have the dentate ligament and the Adamkiewicz artery, the great anterior spinal artery, and posterior spinal arteries. Here is a communication between anterior and posterior in the conus medullaris. Red natural latex was injected into the Adamkiewicz artery under moderate pressure. Look at this. With this injection of this material, we can go to the very thin arteries like this. Look at this. In this sacral nerve, we can see the injection. So once we have injected this spinal cord, we can see this. Let's go to talk a little bit about the great anterior radiculomedullary artery, also known as Adamkiewicz artery. This artery is located in the anterior aspect of the spinal cord, where it took a characteristic hairpin, like this. A left side vessel was present in 45 specimens, and a right side Adamkiewicz artery was present in 5 specimens. Like in this case, this is coming from the right side. Most of them are in the left side. These are another pictures. So look the diameter of the Adamkiewicz artery comparing with the thoracic artery. This is very thin thoracic arteries, and this is the great anterior radiculomedullary artery, Adamkiewicz artery. This is posterior aspect of the lumbosacral segment. We can see in here the veins. This is the filum terminalis, conus medullaris, and the nerves. This is posterior spinal artery. This artery is connected with the anterior, the great anterior spinal artery. And this is the great posterior spinal artery, this one. We are going to talk about this important artery in the lumbosacral segment. The preoperative localization of the arteries is very important in surgical transthoracic spine procedures, and the anatomical knowledge gained preoperatively may reduce the risk of postoperative paraplegia. Here we have the Adamkiewicz artery coming from the high level, the highest level. This Adamkiewicz artery is coming from T3. Here we have the first spinal nerve, 1, 2, 3, 4, 5, 6, 7, 8. The 8 cervical radicular nerves, this one. And then 1, 2, 3. Here is the Adamkiewicz artery in the left side. It was the highest level where we found the arising of this artery. This is a closer view. And the lowest level was from left to. Look at this. This is the lowest level of the origin of the Adamkiewicz artery in the lumbosacral segment. Once we displace these radicular nerves, we can see the Adamkiewicz artery together with this anterior vein, and here the lateral aspect of the lumbosacral segment and conus medullaris. This is the features about this artery of Adamkiewicz was more common in T9, in the left side. Here we have 2 Adamkiewicz arteries, and understanding this basic vascular anatomy of the spinal cord is important to interpret the endovascular and surgical management of this artery. These pictures are really beautiful and demonstrative for these arteries. This is Adamkiewicz artery, great anterior radiculomedullary artery. This is posterior spinal artery. Connection between them in the conus medullaris, and these small spinal arteries, radicular arteries. Anatomy of the great posterior radiculomedullary artery. This artery is very important because, you know, this has attracted little attention and has been a matter of debate. Various authors postulate such a vessel in 1958, 1950, 1962. Others do not mention it or even deny its existence, like Domis in 1980. And according to Jellinger, a large posterior radicular artery is seen caudal in about 75% of instances, with a diameter between 350 and 500 microns. Here we have this artery, no doubt about its existence. And here is a video. This is a great posterior radiculomedullary artery. It is coming along to the 12th thoracic nerve root in the right side. This artery makes a curve and goes to the posterolateral aspect of this spinal cord. Then returns to the posterior aspect between L3 and L4 nerves. Great posterior radiculomedullary artery. Here we have the posterior spinal artery that is coming from the Adamkiewicz artery. This is the posterolateral aspect of this spinal cord. Here we have the posterior spinal artery. This artery is going to make a beautiful anastomosis with the great posterior radiculomedullary artery. A great posterior radicular artery was identified in 72% of spinal cord specimens. Here we have this great posterior radiculomedullary artery. And if we do not know the vascular anatomy of these arteries or also the spinal cord, we are not going to identify nothing in the surgical field. So if we know anatomy, we are going to identify all spinal cord, veins, arteries, radicular nerves. In 22%, we saw bilateral GPRAs. This is the distribution of great posterior radiculomedullary arteries. Most common in T12, in both sides, left and right side. There is no doubt about the existence of this artery. This artery is conclusively present in most 72% of individuals. So now let me show you these videos about the veins of a spinal cord. As you can see, the distribution of the veins is not easy to understand, but what we can see is that in some cases, we have a great posterior spinal vein, only one. And in this case, too many veins going around the radicular nerves, like in this case. So we should have to treat in the surgical field with veins with care. The objective is not damage the vein drainage of the spinal cord. Again, in here, again in here. Look at this. The veins have many veins to drain. And in this case, a few, like this vein. So let's go to other beautiful video. This was a surprise for me to look this injection. It's really amazing and beautiful. And let's go to enjoy this injection of the posterior aspect of veins in the spinal cord. This is what we see in the dural fistula. Really nice to see this. This is the features of dural fistula. Look, here is a component of the dural fistula. As you can see in here, in this part. Here we have the component of the dural fistula. This is the great spinal anterior vein, average diameter 0.8 millimeters. Here we have the great spinal anterior vein. So, think posterior spinal vein, 1.48 millimeters. Doing this dissection, we can get too much information about this. So I am doing also some models made in scale 1/1. They are flexible to understand the spine. So this article, the first article of anatomy of posterior radiculomedullary arteries and the great anterior posterior radiculomedullary artery was written with Dr. Juha Hernesniemi. Thank you so much, dear friends.
Thank you very much, Professor. And thank you for this beautiful dissections and beautiful specimens. Very nice lecture and very nice specimens and very nice dissections. Thank you very much for your lecture. Now we'll move on to our next speaker, Dr. Sameh Al-Mursi. Dr. Sameh, do you hear me? Dr. Sameh.
Yes, yes, I hear you clearly. Do you hear me?
Yes, I can hear you very well.
Okay, I will not open video to make it more easier. I will start sharing my screen now.
Okay.
Uh-oh, looks like Sam is being the boss here.
Thank you, John.
Okay, hello, Sam, welcome.
I am fine. Do you see my screen now?
Yes, but it's big, Sam. It's not correct. There, it's better, but I don't know why.
It's on full screen, if you can.
Yeah, it looks like you got me in. There you go. Can you make it bigger, Sam? The screen.
It's bigger.
Oh wow, you're giving it from your smartphone.
Is it
That's
okay now?
okay. That's okay. Let me get off there, Sam. You're on. You're putting me on the screen. Yeah, that's it. No. Keep me off this. Whatever you want to do, Sam. You can go like this or take me off the screen. Whatever.
Okay. Your image is beautiful. Just keep it. It's okay. Okay, can I go?
Yes.
Okay, thank you. Assalamu alaikum. I'd like to thank the scientific committee for inviting me for this great event. I am Samih Al-Mousi from Egypt, and my talk today will be about microscopic or endoscopic lumbar spine surgery, critical scientific analysis to solve the dilemma. And all of us as a spine surgeon know these images well, which represent different types of lumbar disc prolapse. Different types of disc migration in multiple directions. Big changes, lumbar canal dimensions, and facet joint orthopathy. And I will not go through details about it because all of us know these are the corners. Okay. I hear you.
The screen is not on full mode, on full screen. Are you sharing from your phone or from computer?
It's from my phone. The computer then works. Let me.
You can rotate your phone horizontally, so the image will be in the full screen mode. Now it's appear only in small size, not clear.
Okay.
Oh yes, this is perfect. Perfect.
Do not interrupt. I will start again. Allow me.
If you can.
Okay. Okay. Do you hear me clearly?
Video of the Zoom above it, in top of it. You can only select or remove the video and only show your slide. Yes, that's better.
Is this okay? Dr. Ahmed, is this okay?
Yes, perfect.
Okay. My talk today will be about microscopic or endoscopic lumbar spine surgery, critical scientific analysis to solve the dilemma. And I think all of us as spine surgeon know these images well, which represent the different types of lumbar disc prolapse. Different types of disc migration in multiple directions. Modic changes, lumbar canal dimensions, and facet joint orthopathy. And I will not go through details about it because all of us know these are the cornerstones in taking the best decision for all our patients, plus respect of biomechanics. Then, after we diagnose our patients as lumbar disc prolapse and give them the best chance of medical treatment and decide to go through surgery, we will think about the approach that we go through to achieve our mission in success. Some will think about conventional open surgery, others will choose minimal invasive intervention, either microscopic or endoscopic, and also we will not go through much through comparison between conventional open and the minimal invasive intervention, because it's already more preferable for most of spine surgeons to use minimal invasive than open, unless they don't have the tool of minimal invasive interventions or much training on it. One of the most recent reviews mentioned that Cochrane report has found inferior improvement in minimal invasive intervention regarding back pain and leg pain improvement compared to open. But when you go back to Cochrane review, you will find it published in 2040, which means it needs to be more updated by recent publication, which may change the net result totally. Also, the review have included publications from 1946, which are publications before minimal invasive interventions became more popular and efficient. It makes sense that minimal invasive is more better because logically, if you hit your targets with minimal destruction for the road that you pass through, is more better. You are not Hulk who destroy everything to reach a small success with maximum damage to everything in the road. And I think we came to the era to ask ourselves, which minimal invasive intervention is more better? It is microscopic or endoscopic? And as a trial to answer this question clearly, we need to back to literature to search for some clues to answer. First, we will not find the first level evidence to support superiority of one on other. And this is obvious in every systematic review and meta-analysis available in literature so far. Because so far, we didn't have a double-blinded, controlled study to compare these tools in solid scientific base. In literature, we will find that microscopic spine intervention have been introduced into practice in 1977 by Yashargil and Casper, then populated by Williams. On the other hand, percutaneous nucleotomy introduced by Hijikata, 1975. Then campaign developed percutaneous discectomy in 1986. Then Young started to use arthroscopic technology with irrigation system in a spine intervention in late 90, which is the real start of spine endoscopy. We all agree that microscopic and endoscopic spine interventions has nearly the same advantages and disadvantages. But so far, there are no publications that compared both techniques regarding illumination system, more control on bleeding during surgery, better visualization and differentiation of tissues, better handling of instruments, and long-term outcome. And this is also obvious from the available publication, which tried to review literature to find the answer of this question, which is, what are the best techniques? To find some small difference between both endoscopic and microscopic. So, how to solve this dilemma? To do this, we need some justification for what we have reviewed here. Because in every publication, you will find the same note everywhere, which is steep learning curve. And to make a justification to it, we are still in need to answer these questions clearly. Can we compare an intervention has been started in 1970 by other one started in late 19s? Do we have the same popularity of both interventions? Do we have the same facilities everywhere to use both tools equally? Do we have the same experts equally to give our trainees the same chances? Do we have the same number of training centers which gives the same quality of training of both approaches? Do we have the same numbers of efficient trainers for both? Do we have the same numbers and the quality of publication that we can compare both interventions by fair way? Do we have randomized control trials in high efficacy centers to compare both techniques fairly? Unfortunately, we still don't have clear answer to these questions, but we still find in literature that the both approaches are nearly equal in results, although it's still unfair comparison. We need more training and equal chances for both approaches, techniques to start a fair comparison. These are papers that helped me in preparation of this lecture. And at the end, I denote this lecture for the soul of my dear friend, Professor Amin Al-Kamali. May Allah give him the highest Jannah. Thank you.
Thank you very much. Thank you very much, Dr. Saleh. And may Dr. Amin Al-Kamali rest in peace. And thank you very much for this nice lecture and very important points. Thank you, Dr. Saleh.
Thank you, Dr. Ahmed. Thank you. Yes, yes, sir. Thank you. Thank you.
Now we'll move on to our next speaker, Dr. Prakash Kafle. Dr. Prakash, how are you?
Yeah, hello. Hi, Ahmed.
Can you hear me? Dr. Prakash Kafle is from Nepal, and he's assistant professor, and he's head of department at Mobile Medical College Hospital. Dr. Prakash will talk today. What's the subject? Okay. Yes, Dr. Prakash will talk today about microsurgical clipping of brain aneurysm in the endovascular area. Dr. Prakash, please, you can start.
Yeah. I'm sharing the screen. Just a minute. Is my slide visible there?
We see the desktop of your computer.
Yeah, I'm from the computer.
It's at the very bottom. Yeah, there you go. There you go.
Yeah, is it
Perfect.
visible?
Perfect.
Okay. Thank you, Dr. Ahmed, and all this Yemen Society of Neurosurgery for giving me the opportunity. It is my honor to show my work in front of you and all. First of all, what I like to declare is I'm a skull-based open surgeon. So this may be a biasness that I may not be focusing too much on the endovascular treatment. However, I'm not biased for the endovascular. So here today I will take you for 20 minutes talking about what is the relevance of the microsurgical clipping in the endovascular area. So this is my declaration that I'm not an endovascular surgeon. This presentation, I would like to dedicate my presentation to my mentor, Professor Jua Arnesnemi, whom everybody knows. If a microvascular surgeon doesn't know his name, it is unfair for him. And I would like to acknowledge my institute and my mentors who trained me for performing all this vascular surgery, taking the name from Professor Jua Arnesnemi to my colleague, Dr. Parma Chaudhary. So these are the two institutes where I learned my microvascular training. The upper one is the Tiruvan University Teaching Hospital, which is one of the oldest academic institute in the Kathmandu. And this down one is the institute where I practice now. So these are the contents of my today's talk. So basically, we all know that always the brain aneurysms are the formidable challenge to both neurosurgeon and interventional neurologist as well, neuroradiologist. It is because of high rate of morbidity and mortality, and also because of vasospasm and the rebleed rate. Thus, the prompt treatment of rupture intracranial aneurysm is expected to reduce the morbidity and mortality. However, the natural course of the disease has to be understood. So there is a challenge in a clinic. There is a treatment is a challenging paradigm for both patient and surgeons as well. It is because of potential catastrophic outcome and uncertainty of cure and the need of chronic follow-up. So these are the modalities which I am not going to highlight about these modalities of treatment, basically ranging from the clipping, wrapping to this anastomosis, like coiling, and also the coiling, this flow diverters, etc. So what are the favors and these factors that consider this coiling versus clipping? These are basically because of healthcare environment or facility that the institution adopts, or every institution may not have the facility for both endovascular and clipping in the most part of the countries, like in ours. And the skill and experience of neurosurgeon and intervention, this radiologist or neurosurgeon depends upon the outcome. And obviously the anatomy and the location of aneurysm. Always, all the surgeries are important. However, comparison to the aneurysms location, some become more difficult compared to the others. And also the symptoms due to the mass effect, like this pecum aneurysm. Whenever there is a mass effect compressing the oculomotor, then just by the coiling or this thing will not relieve the symptoms of mass effect. And the age factor is obviously, the higher the age, the outcome. And because of this poor this Karnofsky performance score, obviously the outcome becomes bad. And the clinical state and comorbidities, basically like Huntington Grace and Huntington S grade and the WFNS grade, and this Fisher's grading of the patients. So what is the basic difference in this clipping versus coiling? Is there is not much different in mortality in clipping and coiling. Like if you see the different trials, like we talk about this all BRAT trial or ISAT trial, even the ISAT trial over the 10 years follow-up, what they have shown is in long term there is not much different. So one should be able to clip the aneurysm whenever there is like endovascular treatment goes away. So these are this ISAT trial was the only one trial, the first beginning, which analyzed the outcome of clipping versus coiling. And this was the shortcoming of ISAT trial, I must say, because it was one of the biased trial. Only the 20% of the patient presenting with a subarachnoid hemorrhage were randomized, and it suggests that there was a selection bias. And the more of the non-randomized patients underwent microsurgical clipping than the endovascular treatment. And there was no clear guidance between the microsurgical clipping and the endovascular coiling for the consideration. So the most studies were conducted in the developed countries like Europe, Australia, and Canada, and there was no participation from the like the population like India, and other countries where there are high number of cases. So it is also a type of selection bias. And the expertise of the neurosurgeon and the interventionist were not clearly mentioned. Like if a freshly graduate neurosurgeon clips the aneurysm, obviously the skill what he or she develops may not be adequate to address the exact morphology of anatomy and the feel of these aneurysms. On the contrary, if the expert interventionist does the coiling or embolization, obviously the outcome might be better. So the skills of both has to be compared, which was not properly mentioned in the study. So it has shown that at the long term risks for further bleeding for the treated aneurysm are low with either therapy, although somewhat more frequent with the endovascular coiling. And if we talk about the BRAT trial, what it has suggested at a 10 years follow-up is that the posterior circulation aneurysms were better in coiling group at 1 year, but after 1 year, this difference was no longer statistically significant. So the rate of complete aneurysm obliteration and the rate of retreatment favors patients who actually underwent clipping compared with those who underwent coiling. So thus, the relevance of clipping is those endovascular treatment. Though endovascular treatment is one of the options for addressing this intracranial aneurysm, this international service is not uniformly, this intervention service is not uniformly available throughout the country or throughout the world. It is because of obviously the lack of trained manpower, and there may not be the equipped center everywhere. And the cost is one of the biggest burden, because in the other countries where the insurance policy is high, self or herself has to bear the cost. This is like in ours, and thus one need to develop the microsurgical skill to develop open surgical microsurgical clipping. Ultimately, once if you trust on your skill, then you can give a good outcome. So here I would like to show my personal this series of these cases over last 6 years at my institute, at Nobel Institute of Neuroscience. Like total number of cases which I encountered were 211. and some cases left against medical advice were 36, and the poor presentation, and they denied surgery in 16 cases. And some of the cases with rising, we always give the option for the patient party to whether if you want to go for open surgery or the endovascular. And out of those cases, 7 opted for like endovascular treatment, and the endovascular treatment facility is not still available in my center. So 7 of them were referred, and thus the total number of cases were 152. So talking about the this sex preponderance, most of the patients in the series were female. If we talk about all the series from like my country, like there are 6 papers on the aneurysm and 2 papers from the US and 1 from the France. In all of these series, there is female preponderance. Maybe all the audience in the hall face the same this sex preponderance. It is because of all the hormonal hydrodynamics. And the mean age of the study population was 53 years, ranging from 14 to 79 years. In our country, we hardly get a patient to live beyond 80 years. My friend Ahmed is in the station and cheering. He must know because he was here with us for long, and he knows when the patient is very old in our setup, they usually deny surgery. And the most common presentation in my series was headache followed by loss of consciousness. And there was a good GCS at the time of presentation in the series, and the WFNS grade was like there was good. They were in a high good grade states. The most common aneurysm in our series was ACOM aneurysm, followed by the MC aneurysm. ACOM and the single aneurysm was 93%, and the multiple intracranial aneurysms were associated in 6.6% of the cases. Like by aneurysm location, this 32% of the aneurysms were in our series, more than 60%. If I am not able to see this slide here, I must put this aside. It was 52% in our series, and the MCA aneurysm comprised of 25% in our series. And if you see the different literature comparing from the Nepal, Professor Devkota series also had a this incidence of 41% ACOM aneurysm from Nepal. So most of the aneurysms were cleaved on the second day of the ictus. And the timing of surgery, there is like initially there was saying that when the aneurysms is like patient present within the 3rd days, we operate, or if they present later than that, we don't clip, making it cool. But now the recommendation is we don't wait. Once the patient comes, we evaluate the patient, get the investigation done, and post the case, clip the aneurysm as soon as possible. It is to prevent the rebleeding. And also, if we clip the aneurysm early, we can treat the vasospasm as well. So the average duration of hospital stay was 16.6 days, ranging from 2 to 36 days in some. In our series, the vasospasm was seen in about 26% of the cases, and the other major and minor complications were seen. Like a minor complication in total was seen in 57% of the cases, and the mortality rate was 10%. In series, there was 7.2%, like 11 cases developed the hydrocephalus, and out of these 11 cases, 4 had to undergo surgery, like baby shunting, CSF diversion. CSF diversion rate is very less in our series. And when the patient had long stay and they had a poor outcome or who developed the vasospasm and infarction, they had to go under this tracheostomy, and out of them, this 12.5% of the cases required tracheostomy. However, of these 19 cases, like cases had their tracheostomy closed at the hospital and were discharged without tracheostomy. And we had a good modified ranking scale. Out of this, we had 86% of good grade, and the bad grade was seen in 13%. I would like to show here some few cases we encountered this like complication. We had a lady, 50 years lady with a ACOM aneurysm, WFNS 3 and fissure 4. We clipped the aneurysm on the 22nd October, this 7th October 2023 through the usual terminal approach, and discharged home with MRSF2. But what happened is, like after this 1 month, she presented with hydrocephalus, and we had to shunt. And after the shunt, again in the February, she developed subdural hematoma, and she has to be drained. So this is the CT. With I don't have the CT of acute hydrocephalus. I missed that. So this is the CT scan after doing the VP-son, and because of this VP-son, she had overdrain, and again she had subdural hematoma. And after this, in the second surgery, what we did is we evacuated the hematoma and we ligated this son like siphoning, and then however, we did not remove the BP son at that time. And after that, luckily the patient was lucky and the surgeon was lucky, and she had a good outcome, and she was talking, walking without deficits. So complication does happen. So things like how we manage it. So this is the case of another DACA aneurysm. The surgery went very well, and this was the DACA aneurysm. So through this intrahemispheric approach, intraoperatively there was not much venous congestion seen, and there was no any contusion. However, on the next day of surgery, like when we got the CT scan, she developed like hematoma because of venous infection. And we went and evacuated the hematoma, and again they put the bone back. And after follow-up in 3 weeks, she was all right. So the uncommon presentation, what we always see is this was actually the case of road traffic accident initially, and who on the second visit turned out to be the MC aneurysm. Initially, the reason why we did not do the CT angio is there was a clear-cut history of road traffic accident with the abrasion, and it was unprovoked type of road traffic accident. So we did not go for this CT angio. There was a thick subdural hematoma on 7th post-op day with no post-operative eventful activities. And what happened after the 2 months is like patient presented with this subarachnoid hemorrhage with interventricular extension. We got the CT angio, and between CT angio and the surgery, the patient was like intubated, and like GCS was falling. And when we got the repeat CT scan, the visitors, like patient, we had to inform the patient, and they were there was a dilemma because of the patient party. We did not get the consent for surgery, and patient rebelieved in the theater, and this immediate pre-op to the surgery. So in this case, we went and did this DSC flap and did the microcircle clipping. There was no any intraoperative rupture, and this is the postoperative scan of the patient. And see, and this is the CT scan of the patient. This is the patient like walking without deficits. So now he is walking, and we did the cranioplasty. There is no deficits. So this is the case third. With this complication, what we realize is of the difficult road often leads to the beautiful destination. The best thing is yet to come. So with this hope, again, we have to go ahead when we face the complication. So this is again the 68 years female right-handed. We presented with intact mild headache, and when we woke up, we found a subarachnoid hemorrhage, and then there was a paracolumnar aneurysm. Every surgeon, like every endovascular colleague, will definitely wants to go for the this endovascular coiling for this, but in my institute, I always like give the option. But when the patient says that we'll go for surgery, then I always go for this surgery and anterolateral skull-base approach. And this is a intraoperative video of the same patient. So we did a extradural clinidectomy, and then this is the optic nerve here. So this video is a bit fast. So we dissected, and this was the aneurysm. And here we got this pilot clipping initially, and we got the intraoperative ICG. Once the ICG confirmed, ICG was done, then we did this final clipping, and this is the post-operative CT angio, this BR image of the same patient. This is the area of aneurysm, which was completely obliterated. So this is the one case of the basilar top aneurysm. Like we usually give this preference to the endovascular treatment in this because of unaffordability of the patient. We again had to do this case by open, and we went through the lateral transtemporal approach, and we clip this aneurysm. And this is the post-operative CT scan of the same patient, and there were no deficits. So the conclusion is microsurgical clipping of aneurysm surgery demands high practice. The skills for microsurgical clipping and skull-based surgery cannot be developed in a day or night. Patience has to be there. So preoperative radiological evaluation and 3D orientation is of paramount importance, and the natural course of the disease should be taken care. Just clipping aneurysm is not prepared and not enough. So microsurgical clipping still hold the standard treatment option in the aneurysm surgery. So thank you with this. So I would like to invite you all to the Nepal on coming November. There will be the national conference. So we are hosting. We are the host in the Nepal. So all of you, please welcome. Yes, Dr. Ahmed. Hello. Hello. I'm not
Yes,
audible.
hello, Ahmed. Do you want to take over? You need to unmute, Ahmed.
Can you hear me now, Dr. Prakash?
Yeah, go ahead.
Thank
Yeah,
you
yeah,
Thank you, my friend. And Nepal was a very beautiful country, and they have very beautiful facility and very beautiful hospital with equipment and modern. Thank you very much for this nice lecture and nice cases.
Yes. Thank you, Ahmed. You are welcome next time as well.
Thank you very much. And now we'll move on to our next speaker, Dr. Hussein Sagaf. Dr. Hussein, please come on stage. Dr. Hussein Sagaf is a microbiologist with master degree in medical microbiology, and he's lab manager of the Raji Center and supervisor of the microbiology department at the modern European Hospital. He will talk today about decision making in microbiology for CNS infection. Dr. Hussein, you may proceed.
Okay, what's going on here?
اللي نحن نلاقي فيها نقص كبير من الأطباء اللي هم الجراحين. يعني بعض الأحيان sometimes إنهم يرسلون لنا عينات بس كلتشر أو ووند سواب أو أبسس، يعني رايتنج على البيبر بس كلتشر اونلي، ما في ديتيلز توضح لنا كمايكروبيولوجيست ايش المطلوب، وهذه هنا المشكله. فبعض الاحيان بعض الاطباء تلاقي ساحب ابسس وفجاه لاقي النتيجه انه نو بكتيريال جروث اندر ايروبيك اند ان ايروبيك افتر 48 hours، ما فيش اي بكتيريا. ليش؟ حنشرح ليش. طبعا بس انا اتمنى من الاطباء الجراحين انه بس ينتبهوا لنا من بعض العناوين اللي موجوده عندنا هنا. طبعا نحن نحتاج انه عندنا يكون لازم بيشنت اي دي. البيشنت اي دي كونتين على الديت والنيم والايج والنمبر فايل اذا البيشنت كان في الهوسبيتال، والوورد والروم والبيد. انا اللي يهمني هنا موضوع الكلينيكال داتا وسايت اوف سبيسمين وتايب اوف سبيسمين وبروفيشنال دايجنوسيس. هذه العناصر هذه الاربعه اذا مش موجوده امامي كمايكروبيولوجيست انا ما حاعطي نتيجه ابدا تكون كوريكت، يعني حتكون فيها اشكاليه. يعني بعض الاطباء مثلا ما يعطيني كلينيكال داتا على المريض اذا كان هو في المستشفى، فانا اضطر ان ارجع لملف المريض واشوف ايش اللي كان عنده من مزارع من اول وايش كان تشخيصه من اول عشان اوصل ايش الدايجنوستس اللي عندي علشان اشتغل عليها. الحاجه المهمه دائما اللي تهم الاطباء الجراحين موضوع البادي فلويد، موضوع السي اس اف. اي عينه سي اس اف مسحوبه اذا لم تصل لقسم الميكرو خلال 20 دقيقه انسى تكون في بكتيريا. 20 دقيقه. لهذا الفاستيديوس بكتيريا زي ستريبتوكوكس نيموني ما حتظهرش. ولهذا هي كانت المشكله مع يعني بعض الاطباء ان ما نتواصل متى وصلت العينه يكون هي مسحوبه السي اس اف، ممكن تمر عليها اكثر من نص ساعه. ما تنفعش خلاص. انا لما اجي اعمل كلتشر ما في اي اورجانيزم حيطلع، وبعد يعني حيحصل اشكاليه انه ممكن اكتب النتيجه نو بكتيريال جروث، وهي كانت المشكله في عمليه وصول العينه للميكروبيولوجي ديبارتمنت. هذه نفس الكلام هذا ينطبق على البلاد كلتشر. اذا لم تصل العينه خصوصا السي اس اف خلال 20 دقيقه لا تنفع لان تكون انها تفحص. هذه كانت الاشكاليه الكبيره في موضوع انه ليش نحن نسحب سي اس اف وما يطلع جروث او النتيجه تكون موجوده عندي نو بكتيريال جروث. هذا هو السبب، انه العينه تكون واصله متاخر. وهذه هي الاشكاليه اللي نلاحظها في عمليه سحب العينه للسي اس اف وغالب البادي فلويد. لكن انا يعني جبت السي اس اف لانه يهمنا كثير في هذا الموضوع. الموضوع الاخر موضوع كوليكشن ان ايروبيك بكتيريا. لاحظت بعض الاطباء مثلا في غرفه العمليات يكون ساحب ابسس وما عمل له، حنيجي في السلايد هذا لاحظوا اذا الابسس لم تغطى دايركتلي محط لها كفرنج بالنيدل او في كونتينر مغلق مباشره، ان ايروبيك بكتيريا لن تظهر كميكرو. فنيجي نشوف يعني بس لكن تيجي النتيجه عند الطبيب نو بكتيريال جروث. مش انا سببها، السبب في السحب. الانيروبيك بكتيريا حيحصل لها تموت تماما اذا تعرضت للهواء. فنحن في الميكرو اول ما يجينا بس لازم نتعامل معاه كانه ان ايروبيك. انا حزرع اعمل كلتشر، الميديا اللي انا هعمل لها اختيار هعمل لها ان ايروبيك وايروبيك، لكن مشكلتنا كلها البروبلم في الان ايروبيك بكتيريا. فهمت معي؟ طيب نرجع للسلايد هذا. فالمشكله عندنا في موضوع الاسبيسمنت حق السي اس اف وموضوع الكوليكشن انيروبيك بكتيريا. هذه اللي كانت في مشكله فيها مع بعض الاطباء في هذا الموضوع. ما ادري هو اذا كان هذا الامر انتم يعني سمعتوا به من اول ولا هذا امر جديد، الله اعلم. فهمتوا؟ طيب التي بي بي سي ار يحصل انه بعض الاطباء يطلب اي اف بي. الاي اف بي عندنا اشكاليه في بعض ممكن في اللاب انه انا ممكن ادور ابره في بحر فيحصل فيها بعض الاخطاء، فنطلب سحب عينه اولى وسحب عينه ثانيه. انا عندي بس، فعشان اختصر الموضوع انا اطلب تي بي بي سي ار واخلص، لانه هاي كونفيرم يعني حيعطيني النتيجه اكزاكتلي. تمام. هذه طبعا الداتا اللي تهمنا، اللي دائما نلاقي نقص عليها، انه بعض الاطباء بيرسل لي بس كلتشر سواب او ابسس ويعطيني يقول لي بس كلتشر بدون اي تفاصيل. هذه حتكون فيها اشكاليه كبيره في اثناء الكلتشر لما نعمله حتى في النتيجه. هذا طبعا السلايد اللي انا كنت منوه عليها. طيب سي ان اس بكتيريا، هذه البكتيريا اللي انا اشوفها دائما موجوده عندنا هنا، ستريبتونيموني وستاف ايوريوس وهيموفيلس فلوينزي وايكولاي والستيريا وسيدوموناس اورجونيزا. طبعا في الاونه الاخيره لاحظنا انه اغلب البكتيريا البوسبل باثوجينز اللي في البيشنت تظهر على النحو التالي. الدرجه الاولى تطلع اعلى نسبه سيدوموناس، بعدين ايكولاي وستريبتونيموني والستاف ايوريوس. هذا طبعا انا بس في حاجه تهمهم، بوست اوبراتيف بكتيريا اوف سي ان اس. هذا طبعا لاحظت الجراحين حق المخ والاعصاب يحصل عندهم هذا الاشكاليه اللي هي بوست اوبراتيف. طيب طبعا هذا الجايد لاينز اللي تخصنا كمايكروبيولوجيست اللي نحن نمشي عليه. لاحظوا لي هذه، طبعا هذه مهمه جدا الجايد لاينز. انا يمكن لاحظت هنا سيدوموناس اورجونيزا. This antibiotic for Pseudomonas work in vitro, not in vivo, and not written in the microbiology report. السيدوموناس الامبيسيلين اموكسيسيلين ريزيستنت. الجايد لاينز يقول كده، يعني اي نتيجه عند السيدوموناس لن اضع هذا الانتيبيوتيك، مستحيل اضعها، حتى لو طلعت سنسيتيف لن اكتبها لانها تشتغل ان فيترو وليس ان فيفو. فاللي هي الار ار ار امبيسيلين سلبكتام اموكسيسيلين سيفوتاكسين سيفترايكزون اترابينين وهكذا. هذا الانتيبيوتيك لا تسجل في نتيجة ميكرو في حالة سيدوموناس، ويمنع منعا باتا انها تسجل في الريبورت ولا تعمل داخل المختبر في الميكروبيولوجي. فيمكن بعض الريبورتات اذا ظهرت عندنا بعض الانتيبيوتيك هذه وكانت سنسيتيف معناته هذا خطأ. طيب طبعا هذه ملاحظات امبورتنت سنوت يعني بس نلاحظ فيها. دراج اوف تشويس سي ان اس انفكشن نتكلم من خلال ما نشتغل. اغلب الدراج اوف تشويس انفكشن سيفتازيدين افيباكتام توبرامايسين ايميكاسين ميروبينين. البروبلم المشكله انه السيفتازيدين افيباكتام والتوبرامايسين اللي هم يجيبوا افضل يعني ذا بيست دراج اوف تشويس وإفكتيف غير موجود. غير موجود. طيب الملاحظة الثانية اللي هي النوتس المهم، meningitis bacterial infection caused by staph aureus, it is preferable not to continue with corticosteroid only vancomycin. طبعا نحن بحن نقول للاطباء اذا انت ماشي على كورتيكوستيرويد وطلعت في مزرعه ستاف يوريوس لازم نوقف الكورتيكوستيرويد وندخل الفانكومايسين ونوقف الكورتيكوستيرويد. صارت بعض الاطباء قالوا انه اذا حصل انفلاميشن، بس الجايد لاينز يقول اذا طلع في الكالتشر ستاف يوريوس لازم نعمل ستوب للكورتيكوستيرويد ونعطي الفانكومايسين دايركتلي. الملاحظه المهمه حق الكوليستين، كوليستين ميكروبيولوجي ريبورت written as empirical because not testing. الكوليستين لا يسجل أو لا يكتب في أي مزرعة ميكروبيولوجي، إنما امبيريكال، وليس له اختبار في معامل الميكروبيولوجي إلا حاجة اسمها سيمي ديليوشن ولا تعمل، أو كوليستين آجار وغير موجود في البلد. ولهذا الكوليستين أنا ما أقدر أختبره كميكروبيولوجي عندي في المختبر. ولهذا نتيجة إذا طلعت كوليستين سنسيتيف خطأ، فأنا اضطر إني أكتب كومنت تحت أقول للدكتور كوليستين is empirical treatment إذا كل الأنتيبيوتيك طالع معي ريزيستنت، فالأمر يعود للطبيب إذا يعني يبغى يعطيه. كيف جبنا هذا الملاحظة؟ في الجايد لاينز هنا مكتوب آخر شيء this diffusion and gradient diffusion method should not be performed. لا يكتب كوليستين، لا يكتب في أي نتائج مزرعة. sensitive resistant moderate خطأ. حتى الأجهزة الفول اوتوميشن لما ندخل العينة الفايت وكذا ما يطلع نتيجة الكوليستين، يكتب كرقم بس لا يقول لي لا ريزيستنت ولا مودريت ولا شيء، لأنه ما يقدر يختبره. خطأ خطأ. هذا الجايد لاينز، هذا الجايد لاينز ما يكتب، ما هو الاختبار اللي قال لي الكوليستين سنسيتيف. تمام. طيب امبريك ثيرابي اوف برين ابسس، هذا طبعا في حاله انه ما طلعت نتيجه المزرعه، نحن يمكن اللي يهمنا هنا البوست اوبراتيف نيوروسيرجيكال بيشنت والبنتريتنج تروما اور اناون سورس. طبعا البوست اوبراتيف فانكومايسين اي في لودنج دوز اوف 25 ملغ لكل كيلوغرام then 1 جرام every 8 hours plus ميروبينين. ما يعني انا اخترت هذا السلايد، هذا وفق للسامفورد انتي ميكروبيال ثيرابي في امريكا. هذا الجايد لاينز. الديوريشن هذا اللي يهم. duration of treatment is unclear treat until response by neuroimaging. فأنا أخذت الدراج فوتوشوف الإمبيريك اللي تهم الأطباء CNS في هذا الموضوع، والبنتريتنج تروما اور unknown source، إما فانكومايسين بلس سيترايكزون أو المترونيدازول تحت. طيب عندي هيد تروما بازيلر سكال فراكشر، فانكومايسين بلس سيترايكزون، وعندي بنتريتنج انجري اوف بوست نيوروسيرجيكال مننجايتس. طبعا عندي فيرست لاين وعندي الترناتيف كومنت لاين. برضو الشنت اوف اكسترنال فنتيكولار درين اي في دي، ميروبينين بلس فانكومايسين، والالترناتيف سيفيبين بلس فانكومايسين، الالترناتيف والفيرست لاين. طيب الريكومنديشن هو من خلال العمل في هناك جاب حصل ما بين يمكن الاطباء وما بين الميكروبيولوجي في موضوع الكوميونيكيشن بين دكتور اند لاب. طبعا دائما انا اقول انه راس الهرم هو الطبيب، الصيدلي والمخبري هم تحت راس الهرم. فالمخبري لازم يتواصل بالطبيب على اي سامبل تجي للميكروبيولوجي. ما في شيء اسمه باس كلتشر ووند سواب من فين جات، لازم انا اعرف. ممكن تكون ديب ان ايروبيك انا مش عارف من فين. حتى بعض الاحيان مثلا حتى السسبكتد للكوليستريديوم لازم الطبيب لو شاكك في كوليستريديوم يوضح لي، لانه الكلتشر اللي انا بشتغل عليها تبع السالمونيلا والشيجيلا والباثوجينيك غير الكلتشر حق الكوليستريديوم وغير حق التي سي بي اس، الاطباق تختلف. فاذا انت ما وضحت لي انه المريض انا في سسبكتد في كوليستريديوم ديفيسيل، انا حاشتغل شغل كانه سالمونيلا شيجيلا، وحيطلع المريض انه عنده مشكله مع الكوليستريديوم ديفيسيل بس انا شغال في طريقه اخرى. فلازم السسبكتد لايش؟ لانه كل يعني مثلا الفيبريو كولري نحن نستخدم عليها تي سي بي اس ميديا خاصه، لن ازرع عمل كلتشر على الميديا تي سي بي اس الا اذا الطبيب كلمني قال لي سسبكتد فيبريو، ولا انا حاشتغل سالمونيلا شيجيلا اكس ال دي ودي سي اي وهكذا. وهذه هي الاشكاليه. يعني بعض الاحيان نكتب نو باثوجينيك بس الدكتور طالب شيء اخر في مزرعه. تمام. بروفينشيال دايجنوسيس هذا مهم. سايت اوف سبيسمن لازم الطبيب يقول لي العينه هذه من فين؟ هل من بون؟ هل ديب ابسس وين؟ هل في الابدومين؟ غير كذا المعلومات جدا ناقصه. كولكشن سامبل ان ايروبيك اللي ذكرناها اول، انه مشكلتنا هذه دائما اللي تظهر انه يجينا ابسس في علبه لكن ما يظهرش حاجه. لها تعامل اخر بنقدر نتعامل معه، بس تكون الابسس اللي حصل لها اسبيريشن فيها مشكله فتعرضت فحصل الموت للبكتيريا. السيدوموناس اللي ذكرناها قبل شوي انترنسيك ريزيستنت نوت تيستند اند نوت ريتن اللي قلت لكم عليه في الجدول، اللي لا تكتب في اي مزرعه مذكور فيها سيدوموناس. الكوليستين is empirical not testing. Some antibiotic is important. Pseudomonas are not existed in our country. طبعا سيدوموناس اكثر دراج يجيب افكتيف عليه هو التوبرامايسين انجكشن، بس سالت لم اجد انه عندنا في توبرامايسين انجكشن، وهو صراحه كان يجيب حاجه غير طبيعيه اقوى. المننجايتس اللي ذكرناه بكتيريال انفكشن caused by staph aureus it's preferable not to continue with corticosteroid only vancomycin. انا حبيت اختصر ما حبيت اطول في اشياء كثيره، لكن كان يهمنا هذا موضوع الكلتشرات كميكروبيولوجي. ويعني يمكن انا يعني من الناس اللي لما تجيني مزارع بتواصل مع الاطباء بحب ما اعرف ارقامهم، فاضطر قدر الامكان اجمع اي معلومات. فبحان تجينا مزارع مثلا من المستشفيات الحكوميه حتكون فيها مشكله كبيره، يعني مثلا يجيب لي تيشو كلتشر ويحط لي فورمالين ويقول لي ازرع، ما اقدرش. فهنا مشكله بعض الاحيان تبقى عند طاقم التمريض. ممكن الطبيب يعتمد على الممرض انه يكتب الداتا كلينيكال، الممرض لا يكتب شيء، يعطيني قصاصه ورقيه يقول لي بس كلتشر، ولهذا انا دائما اعمل لها ريجكشن، لا استطيع لانه مشكله. ممكن انا ازرع تطلع كل الانتيبيوتيك ريزيستنت وهذه مشكله اخرى. ففي جاب حاصل ما بين الاطباء وموضوع الميكروبيولوجي في اشياء معينه. عموما ثانك يو.
جزيلا دكتور حسين، معلومات فعلا مهمة. نفتح مجال الأسئلة، وأنا عارف إن في أسئلة كثير يعني أكيد، فنفتح مجال الأسئلة. إذا أردت بس في دقيقة فقط. ذكرت البوست اوبريتيف انتيبيوتيك سنسيتيفيتي للبرين ابسيس، وهو الموست بكتيريال انفكشن السيدوموناس والايكور.
ارفع صوتك ما نسمع.
ذكرت انت البوست اوبريتيف بكتيريال انفكشن الموست كومون. ما ادري هل انت عملت دراسه او ايش؟ تمام. اول بكتيريا السيدوموناس والانشيش كولاي.
هذا من خلال انا ما شفته.
تمام، من خلال ما تشوفه
ما شفته في العمل.
تمام. انا اطرح عليك انه بوست اوبريتيف تحتمل معنيين. تمام. معنى مثلا انا ادخل سبديورال هيماتوما، حصل مثلا انفكشن، هنا بيكون يحمل معنى اخر. البوست اوبريتيف هنا سيرجيكال سايد انفكشن وبعد عمليه كانت نقيه. تمام. فهنا الموست كومون الستافيلوكوكس ايرس بلا نزاع. لكن مثلا ادخل انا البرين ابسيس، هو يجي يدي لك الجراح السبيسمنت. تمام. البرين ابسيس. تمام. البرين ابسيس متعدد على حسب السايت، على حسب مثلا اذا كان قريب من النوز، اذا كان قريب من الاير، اذا كان بالبرفنتريكل، اذا كان تمام بيجي شيء اخر. فهمت عليها يعني انت عمم بوست اوبريتيف.
لا شوف انت ما فهمت. انا اسعى من هذا الموضوع لحاجه معينه، انه الطبيب لا يجيب لي ريكوست يقول لي بس كلتشر او ابسس كلتشر وند كلتشر. لازم يكون عندي داتا. انا ما اعرف من فين جاي البص هذا. هل هو من برين؟ هل هو من بون؟ هل من فين؟ لانه ما ينفعش. انا اضطر بعض الاحيان تجيني بص كلتشر، اضطر اكتب كومنت جنب البص انه العينه جات كذا لما نشرح للطبيب عشان اعرف انا كيف اتعامل مع المزرعه دي والبكتيريا هذه. فهمت انت قصدي ولا لا؟ لان اغلب اللي اشوفه انه تاتي ريكوستات بس ووند بدون اي تفاصيل، وهذه مشكله. انا هذا اللي انا اتكلم فيه.
كويس.
موضوع البوست اوبراتيف والكلام هذه تيجي، لكن انا قلت لك انا يهمني 3 أشياء. العينه تجيني سليمه عشان اشتغل تمام، سسبكتت لحاجه عشان اعرف اشتغل تمام.
في سنة ثانية في حد ثاني عنده سؤال؟ دكتور محمد الوهيب، دكتور ابراهيم جمعان، تيك بليز.
طبعا السؤال اولا اذا كان الانتيبيوتيك سيستم في ان فيفو، هل هذا ينطبق مثلا ولو جزئيا على الانفيترو سيستفتي؟
الانتيبيوتيك عندنا في بعض البكتيريا وفق الجايد لاينز اللي اسمه CLSI. هذا الجايد لاينز المنظمه الامريكيه حق جميع الميكروبيولوجي في العالم، تنزل كل سنه جايد لاينز. طبعا هذه السيدوموناس هذه الانتيبيوتيك تشتغل ان فيترو ليس ان فيفو. يعني انا حتى لو انا في المعمل حطيت سيفتراكزون وطلع لي يعني زون كبير مع السيدوموناس لن اكتبه، لانه مش سنسيف، ما حيشتغلش، لانه انترنسك ريزيستنت لن يعمل. ولكن حصل في التجربه المخبريه طلع هناك في سنسيف، لكن لا يعمل، يشتغل ان فيترو وليس ان فيفو في الانسان.
اخر سؤال. السؤال الثاني يمكن بس الوقت الذي ممكن لان الروبيك بكتيريا تتاثر اثناء سحب العينه، كم ممكن مثلا لو بقيت معرضه للهواء؟
ما يمكن اقل من دقيقه او دقيقه دقيقتين، لانه بعض البكتيريا زي الفستيديا تعمل لنا مشاكل، تموت مباشره. ولهذا تحصل هذه المشكله، انه بعض الاحيان نحن نواجه انه الدكتور يرسل بس يقول لك كيف نو بكتيريا الجروث والبس فين راح هذا؟ فهنا مشكله. فبعض الاحيان نضطر نقول بس cells in gram staining but no organism was isolated. انا عارف انه في بس لكن ما ظهرتش مع البكتيريا، فاعمل انه رجوع للطبيب حصل مشكله. فاضطر بعض الاحيان اكتب امبيريكال تريتمنت، اكتب افكتيف تريتمنت، دراج اوف تشويس. انا اللي اقصد انه يعني الميكروبيولوجي لازم يعطي عين للطبيب انه في شيء معين. يعني مثلا على سبيل المثال ان يطلع عندي مثلا سنسيتيف مثلا 5، ال5 دي في زون اكبر، فاقول له ذا بيست دراج اوف تشويس لو لقيت المسافات ما بين الانتي بيوتيك الثانيه يعني جنب بعض، فاقول له مثلا ليفوفلوكساسين ذا بيست دراج اوف تشويس، ذا دراج اوف تشويس افكتيف ميروبينين فرضا يعني. فهمت؟
دكتور ابراهيم جمعان اخر سؤال. قال الميكروفون دكتور ابراهيم في الصف الاول.
Sorry, Doctor, about pus, يعني sometimes becomes sterile due to antibiotic used for a long time. ممكن يعني؟
لا.
كيف؟
شوف، نحن مشكلتنا في الميكروبيولوجي انه بعض الانتي بايوتيك، طبعا الجايد لاينز هذا انا بعض الاحيان ممكن تجيني مزرعه يورين او مزرعه بص او CSF اي شيء، فانا مش مضطر اني اكتب 20 انتي بايوتيك. الجايد لاينز يقول عندي فيرست لاين، سكند لاين، لاست ريزورت، وهكذا. يعني مثلا تجيني عزل يورين، انا ممكن اكتب في السنسيتيف 3 انتي بايوتيك افكتيف او تشويس، والمجموع كله يطلع 16 14 انتي بايوتيك فقط. لانه انا عندي فيرست لاين، يعني انا بمشي على، انا بقول للطبيب مثلا السبرو بيجيب لي نتيجه كسكند لاين، لا يطلبش منه ميروبينيم وكلام زي كذا. اذا طلع ريزيستنت انا حضيفه، بس انا عارف نتيجه، بس انا حاجب النتيجه.
يعني انت تقصد انه الانتي بيوتيك البص لما يكون ستيرايل ايذر يعني رونج بريبريشن فور بص؟
هو لازم استرايل، مش اهم تجيني العلبه او
لا قصدي يعني اذا طلعت النتيجه يعني كله يعني نو بكتيريا جروث وبس، يعني تقصد انه خطا في تحضير العينه؟
ما شفت انا عمره جاني بس ما فيش بكتيريا اصلا، مش حاجه يعني بتجيني استرايل وفي بكتيريا في بكتيريا. انا اقصد ان لانه انا مثلا عندي، شوف نحن عندنا مشكلتين في الميكرو، انيروبيك وفاستيديوس. فاستيديوس على الشوكليت تعمل لي زي كذا، يعني بمعنى فاستيديوس اذا انا لم اعمل للبكتيريا ادلعها بشيء اسمه شوكليت لن تنمو، ولا حتنمو على بلب ولا ما كونكي، حتروح للشوكليت زي الستريبتونيموني. وهذه المشكله نحن نواجهها مع الستريبتونيموني، انه تظهر في الشوكليت، بس كيف انا ادلل البكتيريا بحيث تطلع وانا شايف البص قدامي؟ فاضطر بعض الاحيان لو استنفذت المحاولات اكتب للدكتور بص سيلزن جرام ستين بط نو اورجانيزم ويز، اتكلم عن نفسي. تعامل وموضوع بالنسبه ما نبغى نخش في موضوع الكوليستين لانه حنخش في جدل كبير في هذا.
Thank you very much. Thank you دكتور حسين. دكتور حامد عمران. دكتور حامد عمران is a senior specialist neurosurgeon at Police Hospital, and he will talk today about his cases in cystostomy and the outcome of cystostomy for trauma cases. Dr. Hamid, please, you can go on.
السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم. Thank you for everybody here hearing my lecture today, and thank you for giving me the chance in the 5th neurosurgical conference in Yemen. Today I'll not repeat the lecture because before maybe 4 or 5 hours professor from India give the same lecture or the same value of my lecture, but today my message, it is for the new generation of young neurosurgeon, because this is the first year of me postgraduate. Most of you know the acute subdural hematoma It is worldwide mortality rate is very high. So there is new technique now start in the world to appear. It is affects wonderful. So Bismillah ar-Rahman ar-Rahim. We will start now the lecture. The lecture today, traumatic brain injury is a major public health concern worldwide. The burden of death and disability from traumatic brain injury has been increasing. The previous or traditional management of traumatic brain injury and increase in intracranial pressure after trauma, it was in the following medical management and sometimes EVD, ventricular drain, decompressive craniotomy, and also surgical evacuation of hematoma if present. So now, recently, potential management for patients with traumatic brain injury is this cystostomy with decompressive craniotomy. Cystostomy with decompressive craniotomy has been shown to have better outcome than decompressive craniotomy alone. Recently, basal cystostomy has been introduced for management of intracranial pressure, and it was not used before that. It was for microsurgical procedure only in neurovascular surgery. Epidemiology of cystostomy is recently produced in 2006 by Dr. I.B. Cherian, been appeared worldwide in 2013 for management of secondary injury of traumatic brain injury. Applying principle of microsurgical neurosurgery to access the skull-base selected cases for severe traumatic brain injury. It also used in opening the basal cistern to atmospheric pressure to allow egress the CSF from ventricles and cistern to subarachnoid space, also helping to reduce the intracranial pressure and cerebral edema. This is the value of cystotomy, and it is used in the subdural hematoma or traumatic brain injury. Indication of cystostomy, it is similar of those for decompressive hemicranotomy, acute subdural hematoma with mass effects and with line shifts, multiple contusion in combination with subdural hematoma and mass effects. Also, it used in pediatric brain injury with severe brain swelling. What is the difference between standard approach اللي السابقة decompressive craniotomy and the newly cystostomy? Standard large craniotomy in both. Skull-base exposure only in cystostomy. In craniotomy, we will not skull-base exposure. During opening, curve line in cystostomy parallel to the supraorbital ridge. CSF diversion via alternative pathway. The first one, it is with EVD. The second, we do internal CSF diversion, opening the membrane of liquid and basal cistern without placement of catheter. Sometimes we need to do the catheter, sometimes we don't need to put it. After that, evacuation of clot and subarachnoid clots in both procedure. Capacious irrigation also in both procedure. Duraplasty, you need it in the previous or in the old procedure, but in the new procedure, sometime and always you don't need to do duraplasty because the brain, it will relax directly after cystostomy. Replacement of bone flap, this is the nice things of this after mortality and morbidity. It is a bone flap. Patient did not need to operation. In the cystostomy, we replace the bone, and in the craniotomy, we don't. What is the advantage of this new procedure? Avoid the external ventricular drain related complication, intracranial pressure monitoring related problem, craniotomy related problem. We avoid this all this problem. A limitation of this procedure. Opening cistern in tight brain, it is so difficult. The patient come with tight brain and massive edema, and it is not easy. Also, the skull base approach itself, it is not easy. Also, it is need to learning curve and to more practice. It may take time to complete the procedure. Injury to vital neurovascular structure as optic nerve and carotid artery, also oculomotor nerve. Technique. Now we will take brief about technique. Patient will be in supine position, the head contralateral to the opposite side and tilted up to 60 degrees in the first. And when we remove the bone, we will reback the head up to 13 degrees to say and visualize the sphenoid wing. And after we do traumatic flap incision and we take the bone, we bore hole, one before and after coronal suture and one at keyhole, and we will remove the bone. After that, we will drill at this yellow arrow. We draw the sphenoid wing bone here at this place up to superior orbital fissure or superior orbital point, and small dissection for dura to not injure the underlying structure. After that, we open the dura as longitudinal incision parallel to orbital ridge, and then we elevate gently the brain tissue and both body with the spatula until see the optic nerve and carotid cistern in this slide. This is the optic nerve, and this is the carotid internal carotid artery. Between them, it's called optic carotid cistern. We open it, and sometime, and most of time, we don't.
We attend once this minute.
Oh, this is Prof. Ibe. Hello, Prof.
Can you see me?
Yes.
Yes, it looks fine.
Hello, Prof.
Yes, hello. Can you see me, guys?
Yeah.
I'm sure you would like to interested to see this lecture.
Yes.
Prof,
Yes, I would be interested.
Prof, this lecture because of you. You are the cause of stand me here at this time and this place. So thanks a lot for you for introduce for the world this procedure and this knowledge.
Thank you so much.
Okay, I'll complete. We open the optic carotid cistern and underline. We have liquid membrane, mesencephalic liquid membrane. We open it. Sometimes you need to put a drain, and sometimes you don't need, because the brain, it relaxes directly. It is a magic. Really, it is a magic. If Prof. Ibe tell you the story how he's discovered this procedure, it is a nice story, inshallah, and he will tell you the story how he discovered this procedure. After that, we both drain and we do duraplasty or don't need to do duraplasty, and then replace the bone and close the skin and follow up the patient in ICU for some days. The patient will be okay. About me, it is the first year of postgraduate. I worked 10 cases until now. Alhamdulillah, all of them, they are alive now without disability. Only one, she has hemiplegia and aphasic until now from the operation time. So this is so happy for me to stand here and to share this information and this important knowledge to young neurosurgeon. It is not difficult, it is so easy. So I'll complete my case report. I bought it here because there's no time to do lecture review. Case presentation, was 4 years old baby, a victim for motor vehicle accident. He presented loss of conscious and convulsion. Glasgow coma scale was 5-15. Patient was intubated in ER, right pupil is fixed dilated, left side body weakness, resuscitation as Atlas protocol. Then this is the brain CT scan. Initial brain CT scan show acute subdural hematoma with massive brain edema and mass effect shifting midline. All criteria and indication of cystotomy is found here. So we operate the patient, underwent urgent craniotomy with hematoma evacuation as IB. Prof. IB cheering the knowledge and the procedure step by step. I start to open the dura here. This is my cases and both the batty under the frontal lobe and open the cistern and directly the brain is relaxed. I'll show the picture after that. This is after I do the cystotomy. I open the dura and I start to evacuate the hematoma. This is the brain. It is a magic. Many neurosurgeon is found here. They say the picture of this brain after subdural hematoma. All of you know how the picture of acute subdural hematoma brain. It is not like this. So it is magic. I thanks a lot, Prof. Ivy, for that knowledge for all the world. Patient, this is after operation 4 days. Patient show progressive neurological recovery and went from mechanical ventilation. After 10 days, patient improved and shifted to ward and discharged after 2 weeks with full neurological recovery. This is the patient. You will say the patient and his voice, please.
مش معك يا أبطال سكر ها سكر ها مش معك مش معك مش معك ها من جدك ها هذا المريض سكر اللي جانا قبل شهر وكان عنده أكيوت سبدورال هيماتوما كان درجة الوعي حقه 5 وكان عنده أنزوكوريا دخلنا العملية في الساعة الأولى وعملنا له سيستومي مع evacuation وردينا له البون فلاب مكانه وهذا الآن بعد العملية ب 25 يوم. ساكر.
Imagine this is your son or your relative. It is a magic. Wallah, and I can't speak. Cystotomy could be appropriate alternative to decompressive craniotomy for management of intracranial hypertension in patients with severe traumatic injury. And thanks a lot for you.
Thank you very much. And comments of the tribe.
Yeah, Ahmed, I am very proud to see what you guys are doing. You know, I've always had a dream that the rest of the world will start teaching the West instead of the opposite. Now, the young neurosurgeons I had seen for the last 20 years, the young neurosurgeons were not really learning much microneurosurgery. The young neurosurgeons were into writing papers. Now I'm proud of you guys. Whoever has presented this, I mean, I am very proud of you, extremely very proud of you. And
Dr. Khalid is a fresh graduate. He's a first year after graduation, and he's an active doctor and a very talented doctor. And he wants to give you some word and talk to you. Please make camera to Dr. Khalid.
Bismillah ar-Rahman ar-Rahim. Dr. I contact you before WhatsApp many times. So I follow you from the beginning, and I see it is experience and it is knowledge. So when in the first case, I'll tell you what was. It was a small baby. It was epidural hematoma in the CT scan. I entered the operation. I opened small bone window above the epidural alone, okay, in the peroneal area. when I opened the bone, I doesn't find the blood. It was subdural hematoma. So I opened the dura, and in fact, with the subdural hematoma, already the brain herniated from the small window and start to necrosis. I remember your lecture. I take the nibbler and I remove the bone until the base of the skull, and I remove the bone until the cephaloid wing. I try to elevate the frontal bone directly, the basal cistern, push directly, tamam, and drain the CSF. The brain relaxed directly without put the drain inside the basal cistern. The patient alive now. He's okay. He's study. So this is thanks. It is for you, not for me. You guide us. So thanks a lot for you.
All I can say is I'm very proud, and I'm very happy that a patient's life in Yemen has been saved because of my technique. I'm so happy that, you know, all the hardships that we have gone through in the first 15 years, and this is the reward for it. To hear this is my reward. So thank you so much. More than you thanking me, I would thank you. So it is my, if my profession and my career had some meaning, this is it. To see that my technique is saving lives all over the world. So thank you very much.
Thank you, Prof.
Thank you very much.
That's
Thank you,
proud
Dr.
for
Hamid.
us.
Thank you, Dr. Aid. And these patients will not be alive without your technique and without your guidance and teaching. And thank you, Dr. Hamid, for this magnificent lecture and for your experience. Thank you very much.
Okay then, guys. Thank you very much. Thank you, Ahmed, for inviting me into this. Thank you, John. And the speaker, I thank him also. God bless. And my best to all the patients who's
His name is Hamid Zamran.
okay. Right. So thank you very much. God bless. And thank you for inviting me. God bless. See you then.
Now we'll move on to our next speaker, Dr. Wada Hakimi. Dr. Wada Hakimi is a resident neurosurgeon at the Thara Hospital. Okay. Dr. Wada will give a lecture about present a case of frontomotor maxillary aneurysmal bone cyst in a pregnant woman. Good, Dr. Wada, you can start.
Hi everyone, I'm Dr. Wad Sadiq Al-Hakimi. I'm a fourth-year resident at Neurosurgery at Thawra Hospital. I'm here to present a secondary aneurysmal bone cyst in the craniofacial at a pregnant woman. Starting with our case, a 20 years old female patient at 19 weeks of gestation present to our OBD complaining from a 2 months history of progressive right side facial swelling next to the right eye, visual disturbance of gradual onset, and the recurrent episodes of self-terminating epistaxis. She also had a chronic headache. At examination, we saw a right orbitomaxillary lesion measured about 5 × 7 centimeters, firm in consistency, ill-defined, freely mobile from skin, and adherent to the underlying structure, deviating the eye to the right, to the lateral side. On examining the eye, pupil was reactive, eye show proptosis, and finger count at 1 meter. Fundus was normal bilaterally, and the ocular muscles was intact. We asked MRI. At MRI, we can see a multiloculated lesion in the T2 coronal section, occupying the maxillary sinus, the right maxillary sinus, extending inferiorly to the left, to the right inferior nasal turbinate, and extending laterally to the inferior orbital fissure, medially to the left ethmoid sinus, and superiorly to the frontal sinus. Mass was deviating, compressing, and elevating both frontal lobes and interhemispheric fissure. As shown in the yellow arrow, red arrow show multiple fluid levels. Our differential diagnosis list was aneurysmal bone cyst, cystic hygroma, soft tissue cavernous hemangioma, Guy's cell tumor, fibrous dysplasia, telangiectatic osteosarcoma, chondroblastoma, and Langerhans histiocytosis, and Young-Carmore bone tumor. At operation, our aim was to achieve a complete resection of the tumor with preservation of the dural integrity. We used intermaxillary approach with supraorbital extension. We dissect the lesion carefully from the maxillary sinus, then decompress it using fluid aspiration to permit further mobilization of the lesion. Then we do dissection toward frontal, ethmoid, and sphenoid sinuses. Dura was also a lesion was completely extradural. Base of the lesion was attached adherent to the frontal dura. We separated from the frontal dura and dissected. Then we used bone fat graft and bi-glue. Grossly, the lesion was irregular with cavities filled with blood and separated by bone septate. Microscopically, histopathology revealed multiloculated cystic lesion with blood-filled spaces containing fibroblast, osteoclast, spindle cells, and Guy's cells tumor. However, Guy's cells were numerous with aggregated nuclei, suggesting Guy's cell tumor as background. Patient recovery was uneventful. There was no symptoms after. This picture was taken after 26 days, showing the complete resection of the mass, the improvement of the proptosis, and the return of the eye to its normal site. Patient was advised for future scheduled follow-up to detect any early recurrence. Aneurysmal bone cyst. Aneurysmal bone cysts are benign expansile lytic lesions that presents 1 to 2% of all bone primary tumors. They are mainly located in the long bones, epiphyses such as tibia and femur, and only represent 2 to 6% in craniofacial bones. Females are more affected than males, and the mean age is 18. They are subdivided into primary or secondary. Primary aneurysmal bone cyst was found to be related to the translocation of chromosome 16 and 17 with Q22 and P13. However, secondary or aneurysmal bone-like changes are not linked to such gene. Their etiology is unknown, and the most antecedent lesion related to the secondary aneurysmal bone cyst are Guy's cell tumor, chondroblastoma, and fibrous dysplasia. Aneurysmal bone cysts usually present with pain, swelling, pathological fracture, and compression symptoms. Compression symptoms differs depending on the site or the location of the lesion. If located in spine, we have neurological deficits due to cord compression, and if located within cranium, we have such various of symptoms such as facial numbness, insomnia, visual disturbance, jugular foramen syndrome, hydrocephalus, increased intracranial pressure, and hemorrhage. Giant cell as the most antecedent lesion of the secondary aneurysmal bone cyst are benign bone tumor that are locally aggressive, and such as aneurysmal bone cysts, they are located mainly in the epiphysis of the long bone. Only less than 1% of them are located within craniofacial bones, especially in the absence of Paget disease. ABC or aneurysmal bone aneurysm during pregnancy. There are some theories relayed on the explanation why aneurysmal bone cysts become more or their growth become higher during pregnancy. The first one is increased hematobiotic activity during pregnancy. The second rely on increased cortisol secretion, which inhibit normal osteogenesis, and the last depend on placental secretion of human placental lactogene that has a growth hormone-like effects. Diagnostic modalities rely on imaging and definitive by excisional biopsy. In imaging, ABCs have a characteristic appearance, multiloculated cystic mass with expansile border and lytic appearance are found within X-ray. Widening of diapobolic spaces, osseous expansion, and narrowing of vascular foramen, ground glass opacity and contrast enhancement are seen in CT, and hypointense lesion on T1 and hyperintense on T2 with hypointense rim and multiple fluid levels are characteristics seen with MRI. Ranking the location of craniofacial secondary aneurysmal bone cysts are mandible, the first and most common place to find, temporal, then occipital, frontal, sphenoid, maxillary, skull base, ethmoid, orbital, parietal, then nasal region final. Common complications present in craniofacial aneurysmal bone cysts are local lysis of bone, either cosmetic and functional, CSF leaks, meningitis, hemorrhagic contusion of the brain, and irritative seizures. Our management goal is to achieve a total resection. This is done using surgical intervention. The first option is to use a classical curettage and bone grafting. We save in-block resection and adjuvant radiotherapy for only recurrent and resistant cases. Other modalities include arterial immobilization, which is a temporary solution used to prevent the expansion only. Argon beam coagulation and high-speed burr, although effective, was associated with distant seeding, making them less favorable in using.
Is there any problem?
So our conclusion is also rare in craniofacial and also present with various symptoms. Aneurysmal bone cysts should be included in our differential diagnosis in bone lesions at the craniofacial.
Thank you, Dr. Watt. Thank you very much for the lecture. And for the next case, we move on to our final lecture for today and the end of our conference. We have now Dr. Bushra. She is a first-year resident neurosurgery. She will present a case, Dr. Bushra Faiz Al-Jabri. She will present a case of Atlantoaxial instability in 15 years old female. Down syndrome presented by torticollis. Dr. Bushra, you can go on.
Good evening, everybody. My name is Bushra Faiz Al-Jabri. I'm first-year resident at Neurosurgical Department at Athlantawra Hospital. It is a pleasure to me to stand here in front of you to present in front of you one of the rarest cases that we may find in our career. My subject is gonna be Atlantoaxial instability in a 15-year-old Down syndrome patient presented by a torticollis. The operation and the diagnosis of the patient was done by Dr. Mohammed Al-Adashi, MD PhD, consultant neurosurgeon at USTH Hospital, University of Science and Technology Hospital. Presented by Dr. Inas Al-Amrani, a 6-year resident at Neurosurgery Department at Athlantawra Hospital, and me, Bushra Faiz Al-Jabri. The content's gonna be the introduction, the etiology of AAI in a Down syndrome patient, differential diagnosis, clinical features, and our case, which will contain a history, clinical examination, laboratory studies, and imaging studies pre-op, and the management, outcome, and imaging study post-operation, and the discussion and references. So as an introduction, the atlantoaxial instability affects 10 to 20%, and some resources say 20 to 13% of Down syndrome population. Only from these percent, 1 to 2% are symptomatic, and the rest of them are asymptomatic. So we gonna diagnose them by radiology, by enlargement of anterior atlanto-odontoid distance. As an abbreviation, we will call it AAOD. Also, the Down syndrome is, as we all know, trisomy 21 chromosome is a condition caused by the presence of an extra chromosome, which is 21, which results in atypical physical and cognitive development abnormalities. It occurs in approximately every 1 in 700 births. AAI, which denotes increased mobility of C2 in relation to C1, occurs more frequently in a person with Down syndrome than in general population, and that's because of ligamentous laxity. The association was first reported in 1961, almost 100 years after Down syndrome was described. Although numerous reports followed, came into the light limb only in 1983 when the Special Olympics permitted individual having the individual of Down syndrome having the condition from participating in certain next stress sports. The upper limit of normal AAOD, which is the measurement we are measuring to diagnose this kind of instability, is 4 mm in subject or patient who are younger than 15 years and 3 mm in older subjects. The anterior space between the atlas and the axis normally opens in the flexion more than the extension, which is why the AOD is greater when the neck is radiographed in flexion than it's in the neutral or extension position. The danger of AAI is that it becomes symptomatic in 1 to 2%, as I mentioned before, of individuals with Down syndrome when the displaced odontoid invasions the spinal cord. The manifestations or the clinical features that the patient will come to us into our clinic to complain with are maybe one of them or even a combination: neck discomfort, abnormal gait, change in sphincter control, upper motor neural lesion, paralysis, and even death. In over 18 of symptomatic patients, this is the end result of a chronic gradual instability. In the remaining patients, where it may be preceded by a normal radiograph, it can be precipitated by neck trauma, sport injuries, endotracheal intubation, head and neck surgery. Patients with symptomatic AAI need urgent evaluation and management, which may include posterior fusion of C1 and 2. Patients with asymptomatic condition need regular follow-up and evaluation as a screening radiographic. The occurrence of degenerative changes in cervical spine of patients with Down syndrome first reported in 1966. As expected, these changes increased with the age of the patient or the population of Down syndrome individuals. This is a picture taken from Greenberg textbook to show us the dorsal view, to show the cruciate and alar ligament that make the dens and C1. The dens is a part of the C2 combined together and stable. The alar ligaments are the peripheral one, and the cruciate is the sides. So the Down syndrome patients have a laxity in their ligaments. So this part, which is the fixation part, is weak. This is another picture from multiple views. So the etiology of AAI in a Down syndrome patient are low muscles tone, loose ligaments due to intrinsic collagen defects, and or a chronic inflammatory state, bony changes which increase with age, and it can be participated by neck trauma, sport injuries, intratracheal intubation, head and neck surgery. As a differential diagnosis, the symptoms or the signs that the patient will come to us complaining of are not specific only for AAI and Down syndrome. It may cross in our minds another differential diagnosis, which are cervical trauma, cervical canal stenosis, cervical ligament injury, cervical radiculopathy, cervical spondylosis, degenerative disc diseases, disc hernia, juvenile disc. So the clinical feature in more detail will be neck pain and stiffness, head tilt or torticollis, neurological defect as cervical radiculopathy with the peripheral upper limb paresthesia. In some cases, symptoms of high spinal cord compression. As an example, slowly progressive spastic quadriparesis, hyperreflexia or a positive Papinski reflex, respiratory insufficiency, abnormal gait, change in sphincter control, and even death. And as I mentioned before, in over 80% of symptomatic patients, this is the end result of a chronic, gradually instability. So my case is a 15-year-old male patient with a Down syndrome and rheumatoid heart disease presented by torticollis. He was complaining of severe neck pain, which started 1 month ago before or primary to admission to the admission date. Pain was acute in onset, stationary in course, associated with upper limb weakness, more at the left side than the right, and dizziness and some choking. He also complained of episodes of sleep apnea. On a clinical examination, the tone was normal in all extremities. Power at upper limb was 4 plus at right side and 4 at left. Both lower limb power was 5, intact sensory and reflexes, fortunately, of all limbs. The laboratory studies was normal because the patient was in his first stages of instability. So viral marker negative, ALT in the normal level, RPS, INR, PTT, PT, serum creatinine, blood probing, and CBC. The imaging that we asked from the patient were cervical spine, AB, and lateral X-ray, pre-op and post-op, of course. Pre-op, we require this to measure the distance that I mentioned before, the EAOD, Atlantoaxial odontoid distance, to measure if it is more than 3 in a patient younger than 15 years, or more than 4 mm in a patient older than 15 years. Cervical spine CT scan, pre-op, if we decided to take the patient into OT, and chest X-ray as anesthetic request. This is the pre-op CT scan. As we can see here, لا مش فيه بس اشتري اشياء اوكي خلاص As we can see here, this is the dense, which is the continuous part of the C2, and this is the distance, the EAOD. And here also, this is an axial view. Here, this is the dense, and this is the anterior part of C1. This is the EAOD, Again, this is the distance that we have to measure to diagnose this condition. This is the chest X-ray. It is normal. So our management and outcome was, patient, according to the CT scan, was diagnosed as a C1 and C2 instability. Then he was prepared for operation. Fixation at C1 lateral masses and C2 pedicles was done. After operation, patient was generally well, power intact in all limbs, and discharged on the second day of operation. 3 months post-operative follow-up. Patient general condition is good, neurologically intact, thanks to God. This is imaging X-ray lateral view, post-op. This is from the outside. This is EB. Okay, as a discussion, the Atlantoaxial joint is extremely mobile, but structurally weak, and is located between two relatively fixed points, the Atlanto-occipital and the C2 and C3 joints. It allows 50% of normal rotation in the cervical spine, but only 10th degree of both flexion and extension. The joint is supported by a transverse ligament, as the previous pictures I show you, which keeps the odontoid process close to the anterior arch of atlas and a pair of alar ligaments. The AI is primarily caused by laxity of the transverse atlantal ligament in Down syndrome patient. This is a part of the general ligamentous laxity characteristic of Down syndrome patient that often results in hyper flexibility of joints. Bony abnormalities of the C1 and C2 region, which are commonly in the Down syndrome patient, also play a role or a part in AAI. Upper respiratory infection, which frequently afflict individuals with Down syndrome, can cause retropharyngeal ligamentous laxity, as the anterior arch of the atlas is only a millimeters away from the pharynx. This is my references, and thank you so much.
Thank you very much, Dr. Bishra, for this lecture and this case. And with this, we conclude the 5th Neurosurgical Conference. And thank you to all attendants and all our speakers, local and international. And thank you, John Bennett on Neurosurgical TV for your cooperation. Although we had today some technical issue, but thank you. Everything is in the end, everything went well. Thank you all, and goodbye.
Yeah, I'd like to say a few words too. Ahmed, yeah, it was great working with you guys. Thank you, Ahmed, for putting all this together. Obviously, video is the future. Video is going to change. It's going to get better. You're going to have icons of Ahmed next to me telling me, John, change the screen. You're going to have little icons running around the field, the screen, consulting with you, saying, "I have this case. Here's Ahmad from Yemen. He came to talk about it." You'll be talking there. I mean, there's going to be amazing things happening in video. technology and video teaching. So stay tuned. It was a pleasure working with you guys. How many years has it been? 5 years, 4 years in a row? I think it's been before you came, Ahmed. We were there. So
4 years. If I came, it's 4 years.
yeah, it's very good. So okay, everyone, have a great day.
Thank you. Thank you, everyone, and goodbye.